I put Haley's potatoes to the side. Good morning.
Good morning.
Good morning. I'm sorry. I'm trying to figure out how to use Zoom. Can you hear me?
Yeah, we can hear you.
Okay. What time does the official, I don't know if I was on the email, because I got the email kind of late. Did it start at 11 or does it start at 10?
So it starts at 9 Central Time. I know we have some people from some different time zones joining too.
Yeah. Okay.
Good morning.
Good morning.
How are you doing?
Good. How are you?
Good. This is Rosemary.
Hi, Miss Rosemary. I'm glad you could join us.
I'm glad I can too.
Did you call in,
Okay,
Miss
I'm on mute.
Rosemary?
Yes.
Which number is yours? What's the last four?
7062.
Okay. I'm going to change you over here and put your name.
Okay, thanks.
this.
Okay.
So
Start talking. Good morning, everyone.
Good morning.
Hopefully you all can hear me.
Good morning.
Good morning.
Morning.
I'm glad everybody is here. And I'm Cynthia Dean. I'm the CEO and Director of Programs of Missouri Boot Hill Regional Consortium. And this is our very first virtual workshop. So we really are excited, and this is an experience. We're excited because we have some phenomenal speakers, and we have a lot of people registered for the conference today. And so we're very excited. But first, I want to recognize our board of directors, our staff, and our volunteers, and many of our clients that are enrolled in our breastfeeding program here at Healthy Start. And we also couldn't have been able to do this without HRSA's support, and we want to thank them as well. But first of all, I would like to acknowledge Rhonda DeBolt, who has done a phenomenal job in coordinating many of our events, and also just basically pulling a lot of the virtual experiences and coordinations of this event together. And so we definitely want to acknowledge her. And so I don't want to take a lot of time because we want to get right to our speakers, and I'm going to ask that Rhonda take over as a facilitator so she can introduce our housekeeping rules, and then we will move forward with the facilitation of our speakers. Thank you.
Good morning. Thank you, Ms. Dean. Okay, so I want to go over just a few housekeeping rules. Let me get that pulled up. Okay, there we go. Okay, so as everybody knows, I think you got a prompt when you came into the meeting, but we are recording the meeting, and we are also going to send that out to everybody after that so that they will have that to refer back to or share if they would like to. We did mute everybody by default upon entry just to limit disruptions, so we just ask that you be mindful. If you do unmute yourself, make sure to mute yourself back. As the presenters are sharing their presentation and going over that, if you guys have any questions, if you could just put those in the chat box and let us know also if you're having any technical difficulties. You're welcome to use the chat box throughout. We're going to monitor that and do our absolute best to respond as soon as possible. And then also for the Q&A after the presenters, we're going to have you guys type those questions in the chat box, and then after they are done, we will refer to those questions. Due to time constraints, we may not be able to get to all of them, but we will do our best to get you a response later. And then also, the data manager, for any questions that you have for her, you can type those in the chat box and she'll either respond that way or by email after the workshop. And so now she is going to give her presentation.
everybody hear me or no? No.
It's really quiet.
Let me. Nothing.
It's still really quiet.
How about this? Can I be heard now?
Yeah, that's much better.
Okay. So I'm just going to go through some national, state, and local breastfeeding data real fast. Some of this other speakers may go on, but we like to show just what's going on in our area. So for national breastfeeding information, these graphs show the percentage of U.S. children who were ever breastfed by birth year. So as you can see, there is a clear increase over the years, and this is by year of childbirth. So from 2010 to 2017, there has been a gentle increase over all breastfeeding and exclusive breastfeeding, which is the child is fed only breast milk, not even water, and that is through both 3 months and 6 months. So that's good that our numbers are overall increasing. If we look at who's doing the best, and I won't say who's doing the worst, but Minnesota, Oregon, Washington, Vermont, and Alaska have the highest rates across the board for all breastfeeding. Alabama, Mississippi, Arkansas, West Virginia, and Louisiana have the lowest, again, for all forms of breastfeeding. And this information comes straight from the CDC. If we look at Missouri specifically, even though breastfeeding numbers are generally going up for the US, Missouri has seen a sharp decrease in their breastfeeding rates. And this is again from the same information source, so all of the children are counted the same way, but there's a clear decline in Missouri's breastfeeding rates for both ever and breastfed to 6 months. This is a quintile map of WIC infants ever breastfed. So the darker numbers are those counties that have the lower breastfeeding rates. WIC infants overall have higher rates of breastfeeding than those families that are not enrolled in WIC. But as we can see, there are large swaths of Missouri that have the lowest rates, especially the Boot Heel counties. And we focus on the Boot Heel counties specifically because that is what Missouri Boot Heel Regional Consortium and Missouri Boot Heel Healthy Start focus on. We focus on those women and children and families in the Boot Heel region. Boot Heel specifically, in case you don't know, are these 5 counties of Scott, Mississippi, New Madrid, Pemiscot, and Dunkland County. We have a very small population for our area and half the population density. It's a very rural area. And our county health rankings for the state are some of the worst, and in one of our county's cases, the worst in the state. Health outcomes and health factors for the entire state of Missouri aren't great, but there are sections that are worse overall in the US. For example, Pemiscot County has ranked 115 out of 115 counties in Missouri for every year I've looked this number up. It has always been the worst. We rank worse health outcomes than St. Louis City, which isn't the best either. Scott County itself, a note that I find interesting is it has actually dropped rank in recent years. They used to be in the late, like 89, 90, and now have dropped down to the 100s to join the rest of our counties. Some of the factors that go into that, social and economic factors, as you can see, I won't read every single one of these out to you. I'm sure these are numbers people have seen before, but our rates for Medicaid population, uninsured population, poverty, no high school diploma, employments, those are very, very high and not very good. In some cases, double the state rates. And health factors are also just as bad for our area. Low birth weight numbers, very low birth weight numbers, infant mortality, preterm, small gestational weight, or small for gestational age. Those numbers are all higher in our counties than overall in Missouri. However, I'm sorry, I'll just refer back to Missouri breastfeeding data. As we've seen, there's been a sharp decline. However, inside of our Missouri Boot Heel Healthy Start, our clients' breastfeeding numbers have actually gone up. So especially in 2019, we saw a sharp increase in breastfeeding at 6 months. These numbers are very low, but that's still double what we had in 2018. And our breastfeeding numbers have continued to increase since 2017. So what we did was we had breastfeeding specific events. These were events created around education for breastfeeding. We've had staff that got additional breastfeeding education. Last year we had 1 CLC on staff. We currently have 5 training, and I believe we have 2 other slots for more staff to be trained. We've integrated breastfeeding education into events that don't have anything to do with, not specifically in breastfeeding. So we've had fatherhood events, we've had, Mother's Day events all around family, but including breastfeeding education into these events. We've increased our breastfeeding specific incentives for clients. We've gotten storage bags, breast pads, cover-ups. We've increased the amount of points. If a mother is breastfeeding, she receives more points for continuing breastfeeding and for completing breastfeeding related goals. So if the client wanted to make it just to 3 months, she got points for achieving that goal. If she wanted to make it to 6, whatever her specific goal was, if she just wanted to try, she had never tried before, but she wanted to try, she got points for attempting to breastfeed. And these things all accumulated in these increase in numbers that we saw. Here's some of our Healthy Start data for last year. What I love about our system, it's all in-house, so I can pull these numbers the second I need them. So like all of the data I pulled before was 2017. For Healthy Start, I can pull 2019. Technically, I can pull 2020, but that wouldn't give a good, clear picture of our program throughout a year. We have a number of objectives from HRSA that we have to meet every year. There are 2 specific for breastfeeding, but we've already talked about those numbers. These are a few that we're especially proud of. 99% of our clients have insurance. 92% of our clients have medical homes. These are very important factors that go into the health of a family that we are constantly monitoring, constantly working towards. If we see a number slipping, we have to focus on fatherhood in the family. We'll focus on fatherhood in the family. If we need to focus on pushing reading for children for 3 days a week, well, we've gotten books and we'll give those books to clients, pushing how important it is to read. And I just like sharing where I get my information, especially because sometimes people are like, well, where'd you find that number? Here's where I found all that information: county health rankings, MOFIMS, Census Bureau, CDC, the BLS. They're great data sources that I suggest everybody use. But yeah, that's just a quick run through some data.
Okay, thank you, Jennifer. Okay, so now we are going to be moving on to our next presenter, which is going to be Miss Kathy Carruthers. So we're going to give her just a minute to get her screen pulled up for her presentation.
First of all, can you hear me okay?
Yes, we can hear you great.
Great. I'll shut that down. All right, let me know if you can see the screen.
I can see your screen. I can see your desktop right now.
All right, can you see the slides now?
Yep, I can see them.
Yay! All right. Well, thank you so much. Welcome to everyone for this important event. My name is Kathy Carruthers, and I work for a nonprofit organization that I head up called Every Mother Incorporated. We provide lactation education and training for healthcare professionals. And since you showed that data and mentioned that Mississippi was in the bottom 5, I feel like I have to stand up for Mississippi because that's where I live. I live on the Mississippi Gulf Coast with my husband and near many of my grandchildren and my children. And I will tell you, we have had an amazing statewide initiative to increase the number of hospitals that are baby friendly. Currently, 20 of our hospitals, 42 in the state, 20 of them have now become designated as baby friendly just in the last 5 years. And our rates have gone way up. We are now past all of those other folks, except for Arkansas. We're tied with Arkansas. It's the first time in decades that Mississippi has not been last. So we are moving and grooving in Mississippi. This photo shows 2 of my beautiful grandchildren, and unfortunately, due to the COVID pandemic, I don't get to see them very often, even though they just live 10 minutes away from me. So I love to have photos of my grandchildren. I know that we have a lot of folks from diverse backgrounds. Again, I just want to welcome everyone to this event. I do have a couple of disclosures for this talk. I do work with the CHAMPS Initiative, which is a organization funded by the Kellogg Foundation to provide training and technical assistance to hospitals to help them become baby friendly. I have been the primary trainer and the Mississippi liaison to the CHAMPS Initiative. I also have a grant with the USDA Food and Nutrition Service. We are developing a national breastfeeding curriculum that can be used by Healthy Start agencies as well as anyone. It will be public domain once it is released. It is an amazing, amazing platform that will be available to the community probably within another month or so. We do have some learning objectives for today. We're going to be looking at ways that human milk helps newborns establish a strong immune system. The title of this talk is How to Support Breastfeeding Families During the COVID-19 Pandemic. So we will be looking at some current recommendations. And we will finally look at some ways to connect to new families with breastfeeding support. And that's important not only during a pandemic, but it's important, I would think, in a rural area like the Boot Hill of Missouri, where you have a lot of very rural communities. I want to begin by addressing first why breastfeeding matters so much, especially in the midst of a global pandemic and in the face of health inequities that we see. For many decades, breastfeeding was really considered a personal choice, just something that we took a hands-off approach. We let the mother decide what she wanted to do, and we didn't interfere with that decision. And then we started learning a little bit more about the importance of breastfeeding. And with
Miss
that,
Kathy,
yes, ma'am.
your audio is kind of choppy. It's cutting in and out a little bit.
All right, would you like me to call in instead?
Let's try that and see if it'll help.
Can you send me a phone link for that, please?
Yep, I'll forward it to you real quick.
All right, thank you. That'll be in the chat box.
The phone link?
Or will that be an email?
I can do it whichever works best for you.
Do email, that would be easier.
Okay.
And can you mute me on the computer, please?
Yes, ma'am. Oh. I'm trying to get that pulled up. Okay. It's coming over now. It's towards the bottom of the email. Kathy, did you get the email?
Can you hear me now on the phone?
What number did you call in? Kathy?
Yes.
Yes.
Okay, say something now. Let me see.
And
All
hello.
right, hello.
Are you the 6368 number?
Yes.
Yes.
Okay, I just got you unmuted over on the side. I'm going to mute you back on the Zoom meeting, and I think, okay, go ahead and talk. Let me make sure we can still hear you. Okay, we lost you again.
Can you hear me on the phone?
Oh, I can hear you. Yep,
Okay, great.
that's
All
much
right.
better.
So
Okay,
we will continue on then. Sorry about that,
perfect.
folks.
It is okay. Thanks, guys.
Okay. All right. So we wanted to begin by really kind of looking at why breastfeeding matters and why it is so critical to the health of mothers and babies. There is a lot of research that, Rhonda, are you, okay, here we go. There's a ton of research now, of course, showing the importance of breastfeeding and why it is so important. Currently, the World Health Organization put it this way. They said in all socioeconomic settings, breastfeeding improves survival and provides lifelong health and development advantages to newborns and to infants. Breastfeeding also improves the health of mothers. And of course, we know other health authorities have similar statements. Thanks to tens of thousands of studies now, we now understand the science behind why breastfeeding is so important and why that truly does matter. First of all, we know that human milk is species specific, and I'm having trouble getting my slides to advance. Rhonda, could you advance? There we go. We know that human milk is species specific. You know, all mammals feed their young through their mother's milk. And the interesting thing is that that milk is very unique to that particular species to help that particular young mammal adapt to the world around them and the conditions that that infant animal is going to be born into. These are a few pictures that I have taken. One of my pastimes, one of my favorite hobbies is traveling all over the world, and I love to take pictures of nursing mammals wherever I go. I have quite a collection that has started, and I really enjoy that because it reminds me of just how unique our milk is made for our young. For example, did you know that human milk is around 4% fat, and it has amazing properties that are designed for brain development? But in other species, that may not be the case. When I was in Australia a few years ago, I went to a little island off the coast, and there was a wildlife refuge there of a colony of seals that were being protected from extinction. And I took some pictures there of mother seals who were nursing their young. Did you know that mother seals make milk that is 60% fat compared to 4% fat in humans? And that's because baby seals quickly build up layers and layers of blubber that they need to adapt to frigid temperatures. They also have moms who go out to sea and forage and leave them alone for days on end. So they have to have a very different composition of milk. And I find that to be really fascinating that our milk is able to do that. We know that human milk is also different from formula, but a lot of mothers don't realize that. They don't really understand that there are differences. This is a photo of what a drop of commercial infant formula looks like under a microscope. And you can see that there isn't a whole lot to see because formula is a manufactured substance. It's not living. So it has about 50 to 60 ingredients. It is, however, marketed as being very similar to breast milk, but nothing could be further from the truth. This picture on the right now shows what a drop of human milk looks like under a microscope. Human milk is a living substance. This means it's constantly changing depending on the growth and development needs of the baby. And it also changes throughout the day and even throughout the feeding itself. According to some estimates, although formula contains about 50 to 60 ingredients, Human milk actually contains more than 100,000 constituents. And these ingredients are perfectly suited to the growth and development needs of the baby. In fact, every teaspoon of human milk contains over 1 million white blood cells. And most of these are what we call macrophages, or Big Macs, or the killer cells that go throughout the baby's body looking for bacteria so that they can destroy them. Human milk also has an ingredient called Hamlet, and that sounds like a Shakespearean play, but it's also the name given to a molecular compound that's composed of certain proteins and fatty acids that glom together and form a whole new molecular compound. And this compound that they've named Hamlet has now been proven to be lethal to 40 different types of cancer cells. This picture is one that I really love. It beautifully shows just how unique breast milk is. This milk in both of these bags was expressed by the same mother within a day apart. And the milk on the left was the first milk that she expressed the day before, but the next day, when her baby became ill with a little cold, her milk completely changed in color. And that is because human milk, when a baby is exposed to viruses and bacteria, higher amounts of IgA, which is the primary antibody immune factor in human milk, as well as lactoferrin, which is also a primary immune factor, those dramatically increase in quantity, and it changes the color of the mother's milk. I find that to be amazing, that a human mother, her body somehow knows what her baby needs, and she produces exactly what her baby needs. Mother's milk has also been shown to significantly affect a baby's microbiome. Now, a microbiome is simply the name that we give to the collection of microbes that live in our bodies. And our body is actually a virtual zoo of bacteria and viruses and fungi, all of which live together in balance. Each human being has a very different microbiome, and these microbes play a really important role in digesting our food and really bolstering our immune system. So, for example, did you know that we have around 700 different species of bacteria that live just in our mouth and in our noses? We have another 400 species that live in our skin, and about 40,000 different species that live in our gut. So these microbes are really important to help balance our body and help us to stay healthy. Now, babies are first exposed to the mother's microbiota in the mother's womb during pregnancy. So the mother is essentially passing down to her baby this mix of microbes that her baby is going to need to function well outside the womb. In the last trimester, there's a dramatic increase in the number of species of microbes that are available in the mother's vaginal tract. And that is designed to help expose the baby to these unique microbes during the birth process. And then after the birth, once the baby is placed skin to skin, the baby now is able to colonize to the 400 or so species of microbes that are available on the mother's skin. So breast milk then, when the mother begins to feed her baby, completes the process by sending a very vast and diverse array of microbes into the baby's gut. And these microbes help the baby not only to digest food, but to bolster the baby's immune system, which will help that baby for life. Now, we also know that exclusive breastfeeding permanently alters the baby's immune system. So as you can see, this picture was on the cover of Life magazine a number of years ago, and it shows a picture of the baby's thymus. The thymus is an organ that is located between the baby's lungs and behind the baby's sternum. It's considered the central organ to the baby's immune system. And what it does is it grows lymphatic tissue that harbors all these white blood cells, and it also grows those important killer cells that we talked about a while ago that help regulate the baby's immune system. Now, why this is important to breastfeeding is that researchers have now found that the thymus of an exclusively breastfed baby is twice as large as the thymus of a baby who receives formula. So when a mother is exclusively breastfeeding her baby, she is helping her baby lay down the lymphatic tissue that this baby is going to need to fight disease and infection for life. breastfeeding matters, and it especially matters during an emergency. I know in Missouri, you guys are right in the pathway of Tornado Alley, and that's a huge issue. In your state, I grew up in Oklahoma where tornadoes were a really big deal. I now live on the Mississippi Gulf Coast where our natural disaster is hurricanes. We know that no matter what that emergency is, that breastfeeding can be life-saving for babies in the midst of emergencies. And there's all kinds. There's everything from natural disasters, things like wildfires that can occur, or maybe something like a house fire, an individual personal emergency like a house fire, or maybe a family member who loses their job, or the results of war or domestic violence, or a global pandemic. And we know that anytime there is an emergency, the vulnerable populations are the ones who are most at risk. So who are the vulnerable? Well, the vulnerable are those who live in poverty, those who live in poor living conditions, those who are have medical conditions, who are in poor health, people of color, infants, and children. These are all among the groups that constitute vulnerable populations. This photo was taken after Hurricane Katrina occurred in my state, where 56,000 women and 75,000 infants were directly affected by this horrible disaster. And because the breastfeeding rates were so low at that time, we lost many, many infants due to that horrible disaster. This photo was taken by a local breastfeeding group. They sent this to me, and I really love this. It was designed to demonstrate the importance of breastfeeding in an emergency. And you can see on the left that there's not a whole lot that's needed if a mother is breastfeeding. On the right, you see that in an emergency, mothers need a lot of things. They need clean water. They need the ability to clean the feeding utensils. They need appropriate formula, not powdered formula, because powdered formula cannot be made sterile at all. So unless you boil the water and mix that with that powdered formula, it is not going to be safe because bacteria can live in that. So we know breastfeeding is crucial. In fact, the WHO reports that infants who are not breastfed during emergency situations, they are 14 times more likely to die than babies who are breastfed. And that's because human milk produces those antibodies. And we know that human milk even produces antibodies that are specific to the contaminants in the environment. So human milk protects babies from diarrhea and respiratory illnesses. It doesn't require mixing with formula and water, doesn't require safe utensils, doesn't require cleaning. It only requires a mother who is willing and able to feed her baby. You know, I think we can think about what are the things that increase a mother's risk or increases a baby's risk during an emergency. If you'd like to use the chat box and type in a few ideas of things that you think might contribute to that, I'd invite you to do that now. We aren't going to have time to really digest those in real time here, but I'd be interested to hear from you what you believe might be some of the reasons that babies who are not breastfed are going to be at increased risk. And certainly, I think things like lower rates of breastfeeding, poor health status, lack of access to basic necessities, food insecurity, sanitation issues, these are among the things that can contribute to poor health outcomes among infants when they are not breastfed. This is a picture that was taken in a grocery store a few weeks ago. Some of you remember all too clearly how many people were stockpiling food and other necessities like toilet paper as the COVID emergency began. And it just reads a reminder to me of how vulnerable populations are at such a disadvantage. They may not be able to access or to afford stockpiling food during an emergency. And then when they really do need those items and are trying to get to the grocery store, it's very difficult for them to find foods and the supplies that they're going to need. Of course, today we are facing an international emergency with this COVID pandemic. It has affected 20 million people in every continent except Antarctica, in nearly every country of the world. There's only a handful of countries that have not been touched. They are primarily very remote islands around the world. Just a few, 5 or 6 countries that have not been touched. 5 million of those 20 million global numbers live in the United States, and more than 168,000 as of last night have now lost their lives to this disease. As we know, the CDC is monitoring the data very carefully, and the preliminary data is showing that the virus is affecting disproportionate numbers of people of color. The CDC reports that while 59% of the U.S. population is Caucasian and 33% or 18% is African American, but among COVID cases, 45% of hospitalized patients are Caucasian and 33% are African American. And you can see from that purple box, the other category includes Native Americans, which we know are also disproportionately represented in COVID cases and death. The CDC attributes these disparities to increased risk of underlying health conditions among people of color, such as high blood pressure, diabetes, other indicators. But they also have noted that people of color are more likely to have less access to health care. They may be less access to health insurance. Thankfully, in the Boot Hill region, as you all mentioned, many of your participants do have health insurance, so that is fantastic. But we know people of color also rely more on public transportation, where the spread of the disease may be more likely. And we also know that during this pandemic, a lot of people were forced to work at home, which is really great if you have the kind of job that allows you to work at home. But unfortunately, among many underserved populations and vulnerable populations, working at home is not an option. And we also know that being able to care for sick children or being able to stay home it also limits people in terms of childcare. So the issues are indeed huge. I did take a look at the Missouri disparities statewide, and I found as well there were very similar patterns of disparities. In your state, 82% of your population is Caucasian, 11.5% of the population is African American, 4.1% Hispanic, 2.6% are other. And yet you look at the deaths from COVID on the circle on the right, and we see again disproportionate numbers attributed to African Americans, other populations, and Hispanics. And then I took a look at just the St. Louis disparities, just to see one city in your state, and we also see significant rates of COVID infection and death among African Americans, almost twice as much as Caucasians. So this is a serious, serious health issue for vulnerable populations. And we know that breastfeeding is one way to help mitigate some of these health disparities in infant mortality and morbidity. So what do we know about COVID? Well, based on the data we have now, and keep in mind the data is still emerging and changing. We're hearing more every day. But currently, there is no evidence that's been able to prove that breast milk contains the active COVID-19 virus. So that is really good news. We've also seen some preliminary studies that found that when mothers are COVID positive, that they actually produce COVID antibodies in their milk. So this potentially has the potential impact of perhaps protecting that infant from the virus. We can't say it guarantees that at all, but we certainly know that there's some exciting research underway to see if possibly this could be true. Now, we do know that if infants contract COVID after the birth, which has happened in a number of cases, that they typically do experience mild symptoms. However, you know, that research is still emerging as well. At the current time, the WHO urges mothers to breastfeed. They state that the numerous benefits of skin-to-skin contact and breastfeeding substantially outweigh a potential risk of transmission and illness associated with COVID-19. If a mother is positive and she's too sick to be able to breastfeed, the WHO suggests that mothers express their milk or consider using donor human milk for their baby. Here in the United States, the CDC also urges mothers to breastfeed. They say breast milk is the baby's best source of nutrition, And they also state that breastfeeding is not likely to be a source of transmission of COVID. However, they do recommend that mothers work with their healthcare provider and make those decisions together, because each situation is going to be unique. We know that some babies are sicker than others. Preterm babies are going to be more at risk. So that's a decision that really should be made with the baby's physician. But I think we can give some tentative guidance at this point to mothers that breastfeeding is extremely important because of the changes that we know that breast milk has with regard to exposure to bacteria, pathogens, and viruses. So there are some basic precautions that the CDC recommends, and of course, these are nothing new. You all have heard all of these precautions, the importance of hand washing. So for a breastfeeding mother, she should wash her hands before feeding her baby to help avoid spreading the virus to the baby. She should wash her hands before she touches the baby. Oh, and if she's not able to do that, she should be using a hand sanitizer that is at least 60% alcohol to do that before she handles her baby if she is COVID positive. Also, mothers should be wearing face coverings while they're feeding the baby if they're COVID positive. Some experts are now suggesting that maybe if the mother is COVID positive, if she coughs or sneezes over her bare breast, she might want to consider washing her breast before feeding the baby. But that's just not a recommendation of the CDC yet. And we do need a little more research before we recommend that. But it does kind of stand to reason that that might be something she could consider, because we do know that the COVID virus does stay alive on surfaces. There are some great resources from CHEER, which stands for the Center for Health Equity, Education, and Research. They are the organization out of Boston University Medical Center that manages the CHANCE program that I'm affiliated with. And they have developed some really awesome videos for parent education. And in your handout that is available for this talk, I've provided a whole lot of resources, a whole lot of web links for you, and this web link is included there. One of their videos it's kind of cheesy and a little silly, but it shows women how to wear a mask properly. And they show all the wrong ways to wear your mask, and then at the end they show the right way to wear a mask. There's also a video on hand washing, another video on the importance of breastfeeding during COVID, and they're all designed for new parents. In some cases, a mother's physician might advise her to express her milk to feed the baby by a healthy caregiver if the mother is too sick to be able to breastfeed. Even among healthy mothers, many mothers are choosing to exclusively pump rather than directly breastfeed. And some mothers are breastfeeding, but they are also pumping their milk. We often recommend that mothers consider pumping while they're also breastfeeding in those early weeks before they go to work or before they're going to be separated from their baby, because it really helps to initiate a high production. It kind of sets a high calibration point for their milk production. So with that in mind, we also need to be giving mothers advice and recommendations on how to pump safely during the COVID crisis. The slide displays a CDC document that is now available for parents. It's titled How to Keep Your Breast Pump Clean. I've included the link to this in your handouts as well. They also have some home guidelines, and they do recommend covering your cough, wiping surfaces, and washing hands if a mom feels that she is sick or she has some symptoms, recommending that she stay home. So this is a great resource to pass along to parents. The CDC also advises mothers to wash their hands before using a breast pump, and even taking some sanitizing wipes and wiping the outside of that breast pump, including wiping down anything the mother's touching, which include the dials on that pump. And if she's going back to work, and if she's using a breast pump that's available at work, or even using her own pump, it's a good idea to suggest she include some sanitizing wipes and wipe down her pump and the dial switches. She should also clean any pump parts that come into contact with her breast or her milk by holding it under running water. And then she can fill a separate basin with hot soapy water. And you want to wash these pump parts in a separate area from other parts. So I recommend moms just go and get a 99-cent or a $1 plastic basin that you can get at a dollar store very easily, and use that to fill with hot soapy water and wash those pump parts in. And then after you wash them, you can rinse it off with water and place them on a towel to dry. A lot of people are also recommending that mothers sanitize their breast pump parts. They can put them in a dishwasher. The dishwasher has a sanitizing cycle. If they don't have a dishwasher, they can place all these pump parts in a large, like a Dutch oven type pot, and fill it with water. In the South, we have chicken and dumpling pots. They're big old giant pots, and that's what we use down here in Mississippi. Fill it with water to where you cover all the utensils, and then bring it to a boil. As soon as it comes to a boil, take it off the heat. Use some tongs so you aren't using your hands to lift those items out and put them on a clean towel. I believe there are also sanitizing bags that you can buy that you can put the pump parts in a microwave, and that will also help sanitize them. If a mom is going back to work, I know a lot of Healthy Start and WIC mothers do return to work. It's amazing how many mothers do return to work, and many of them are returning to work in not necessarily office environments, but if they have access to a pumping room, we suggest that mothers wipe down the surfaces with antibacterial wipes after they are through pumping. I also wanted to mention that the CDC has issued some guidelines. They did this jointly with the USDA Food and Nutrition Service for how often or how long to store human milk. This is available as a free download. You can get magnets with these guidelines. I recommend that programs just print these off, have them laminated, and pass those out liberally to moms so they can put them up on their refrigerator. Breast milk can keep it up to 4 hours at room temperature, 4 days in the refrigerator, and between 6 and 12 months in a deep freeze. So what other things can we do to support new families, especially in a global pandemic? So I'd like to use these next slides to talk about some things to keep in mind from pregnancy through the postpartum period. Pregnancy is an ideal time to plant seeds of confidence. So you can tell mothers during pregnancy that there's currently no evidence that babies can catch COVID before they are born. And in fact, there was a recent study found that they could not find the presence of COVID in a mother's amniotic fluid or in her vaginal secretions. So we feel at this time that mothers are not really transmitting COVID during pregnancy. However, a pregnant woman can catch COVID herself during pregnancy, which could compromise her own health. So we need to remind mothers to be extra careful, to avoid being around crowds of people, to wear a mask when she is out in public, to wash her hands frequently, and certainly to keep her prenatal appointments. Pregnancy is also an important time to help a mother make an informed decision about breastfeeding, and that includes helping them to identify their barriers to breastfeeding, finding out what might stand in their way. You know, for a lot of women, and I have dealt with thousands of mothers across this country, and I hear from many women prenatally that they believe breastfeeding is impossible because of all of the fears and concerns they have. They may be worried that they're not going to make enough milk, or maybe they're worried that family members are going to criticize them. Maybe they're worried that their partner will not be supportive. There's so many fears that women have, and now they have an added fear about COVID, and that perhaps is going to add some kind of a fear that they won't be able to breastfeed. So what we can do is to take off that I am, to turn impossible into possible by addressing their barriers and showing them solutions for how to make breastfeeding work. We want to talk to them also about the importance of the magical first hour, that mothers can get a great start with breastfeeding by staying close to their baby in that first hour and continuing to hold their baby skin to skin in the hospital. I want you to know I included a link for this. The American Academy of Pediatrics has just issued new guidelines to update their original guidelines. Their original guidelines that were issued back in March suggested that mothers and babies should be separated due to COVID after birth. They've now amended those guidelines and say, oops, we were wrong. We should not be separating mothers and babies. We should be keeping them together. So make sure you take a look at that and pass that along to health providers that you work with. In the hospital stay, we can also encourage mom to decide on a champion. Many hospitals for a while We're not allowing the baby's father or any other visitors to be at the hospital. I understand that many hospitals now are allowing one person to be at the hospital, and oftentimes that person needs to be admitted with the mother and they stay with her together until discharge, and they are discharged together. So the mother needs to be thinking now about who that person is going to be, and if the baby's father or her partner could be a same-sex partner. I mean, there could be a lot of variations of who that champion is going to be. If that person cannot be with her, think about some things that they can do to provide support long distance, maybe through FaceTime and other means. I also think it's important to prepare moms for expectations. This is one of my favorite photos because this is the idyllic dream. This is what every new mother believes her hospital experience is going to be like. She's going to have her doting partner right there at her side to, just make her feel wonderful and adore and worship her for the experience that she's just been through. They dream of the dream baby who is going to be sleeping all the time, the beautiful, perfect baby. And the mother, of course, is going to be resting in this wonderful scene and getting lots of sleep because, that's the dream we all expected. And that may happen on day one, particularly with a little more of a sleeping baby. Babies do tend to sleep a little more on day one, but the reality kind of hits home on day two. And day two is when you realize maybe that dream I expected is not going to be what I thought. The baby's going to wake up a lot more. The baby's going to be fussier, a lot more fretful. So we want to share solutions for moms on how to calm that fussy baby, things that we can do besides good formula to help that baby to calm. And one of my favorite recommendations is to suggest that mothers try repetition, to repeatedly move the baby, swaying the baby repetitively. Her champion can help with this as well. Skin to skin is probably the very best thing to recommend a mom use with a fussy baby because that releases hormones in the baby that help that baby to lower stress levels and help that baby to calm. You can also suggest that the mother look for feeding cues that the baby will show. That might be very simple things like sucking on their fingers, making mouthing movements. And I always tell moms, if you're waiting until the baby cries before you feed the baby, you've waited too late. Crying is not a feeding cue. Crying is a call for help. That's an SOS. That's the baby's way of saying, somebody save me. Somebody save me. I'm dying here. Somebody needs to come in and feed me. So you don't want to wait that long. And we do know from research now that when a mother feeds her baby with the earliest feeding cues, that a baby stays calmer and a baby will be more likely to show those feeding cues whenever they're hungry because we're going to be reinforcing that positive behavior. Of course, I think it goes without saying we need to show moms the importance of a really good latch. This is a fabulous good latch here. And we also want to remind mothers that the first milk is going to be very small in quantity, but it's going to be very rich in immune components that will help protect her baby from illness. I like to tell mothers that their first milk is a little bit like a can of frozen orange juice. Orange juice in a can is very concentrated, and when you start adding more water to it, it is going to increase in volume, and the same is true for that first milk. It is important as well to talk about the role of fathers. I know Tom Johnson is going to be talking about this, so I won't go into detail, but I do want to say during COVID, it is even more important that dads be present with that mother, particularly in the hospital. If they're not able to, I even suggest if dads are not able to be at the hospital because of hospital policies, that they FaceTime their partner frequently, that they get the home ready for the mother for her return, that they hold that baby skin to skin a lot when they're home. If the dad is able to be in the hospital, I always urge healthcare providers to remember that dads are an extremely important part of this process. This was a photo that we took in Michigan of a mother. We were trying to demonstrate the importance of getting that mother immediate help. But unfortunately, when the picture came back, I said, hey, why is the dad sitting over here on the side? They have ignored this dad. This dad is feeling invisible right now. And they said, well, he doesn't seem to be very involved. And I said, well, let's try letting that dad hold the baby skin to skin so he can understand why this is important for him too. So they did, and this was a picture that was taken of the same dad who became much more engaged and much more involved when he held his baby skin to skin. So this is crucial, and I'm excited to hear what Tom will be sharing about the importance of dads in his talk. Once the mom is home from the hospital, she needs continued positive messages from you, whether you're WIC staff or hospital staff or Healthy Start staff, the importance of the fact that early weight loss is normal. Babies will begin to regain by around day 4 or 5, and they should be back at birth weight by around 10 days, certainly for sure by 2 weeks. I tell moms you cannot measure what goes in. There are no tick marks on your breast, so you cannot measure it. But you do measure what goes out, because what goes in has got to come out at some point. So you want to count those pees and poops. I tell moms to remember this phrase, 8 or more in 24. So feed the baby often and get help with challenges, because there are solutions and there are people who can help you. I also urge mothers to continue to check in with the pediatrician, to keep all those pediatric appointments. And if they're worried about the baby catching COVID at the pediatrician office, I want to just remind them pediatrician offices are prepared for this, and they will tell you what to do. They will probably urge you to wear a mask. They may urge the mother to wash their hands or use hand sanitizer before they come into the clinic. They're probably going to take your temperature before you walk in the building. They may only allow one person to come in, and if that's the case, I always recommend that the mother or the breastfeeding parent be the one to bring the baby in, particularly when they're going to be giving shots to the baby, because when those immunizations are occurring, we know that breastfeeding provides pain relief for the baby. So if the mother can hold the baby and breastfeed while the shots are given or immediately after those shots are given, that mother's able to provide immediate comfort to her baby. And of course, we want to refer mothers to healthcare professionals and lactation experts anytime anything doesn't seem right. So if the baby has scant bowel movements, the baby is sleepy and not waking up on his own or her own to feed, if the baby has jaundice, turning a little yellow, if mom is worried she's not making enough milk, if the baby's not back at birth weight by 2 weeks, or if the mother is still having nipple pain. Now, nipple tenderness is normal. It's pretty common in the first hours and maybe first few days, but it should not continue. If it does, that's an indication that the baby may not be latched well, which means the baby is not going to be transferring milk and will not gain weight appropriately. And this is also going to affect her long-term milk production. So it's really important for the mother who reports pain get immediate help and assistance to deal with that. And certainly if there are any medical issues. Now, in the final minutes, I want to talk about a few things to keep in mind, some ways to reach your participants, particularly during this COVID crisis. Many WIC agencies across the country are using Zoom, the platform we're using for this conference, to conduct breastfeeding education with their mothers and to train their staff even. This is a picture of a peer counselor staff training that was conducted in North Carolina by a WIC agency there. And I love this picture. They are learning how the breast makes milk. They're using the USDA curriculum that we've developed, and one of the activities in there is to blow up a balloon and get a pen or a marker and draw a breast as you're learning about the parts of the breast. So they had all their peer counselors blow up their balloon at home and show off what they were drawing. And so I think that's just a great way to provide support directly to your staff. In Vermont, they not only conduct regular breastfeeding classes, prenatal education, they actually have a back to work class for new mothers. So mothers can get on their Zoom meetings and they listen to one another. They also invite the mother to bring their partner and whoever's going to be taking care of their baby. Many of the WIC mothers will use their own mother or a family member to care for their babies. So they invite them to the Zoom meetings, and that way they can all learn together how they can provide support for that mom when she goes back to work. In Mississippi, we have what's called baby cafes. You may have some of these in Missouri. We have about a dozen baby cafes scattered throughout the state. And we now do our baby cafes through virtual means. They're done through Zoom meetings. And it has been a huge success. Mothers really, really look forward to these meetings. You know, people wonder, when are we ever going to get back to in-person meetings? But many of the mothers are telling us they love the Zoom meetings because they don't want to get their newborn out anyway. They like being able to do this from home. And because we record those meetings, they can even tune in later if they had to miss the live session. In several states, they are using FaceTime and Skype and other secure platforms to provide video conferencing lactation consultations with mothers. So in Texas, they are doing this in several areas around the state where a mother can call in to a lactation consultant and get direct assistance. In many cases, the lactation consultant may live in a regional area in the state. She might be 200 miles away from the mother, but they're able to provide that support. In this case, the lactation consultant is using a breast model to try to explain to that mother how to do breast massage to that mother who is feeling really engorged. In New York City, in the Bronx, they use live stream chat rooms through Facebook to stay connected with their moms. And one of the things that they discovered in New York, because there was such isolation during the spring when so many mothers, families, and people were affected, that they found that the incidence of postpartum depression had skyrocketed during the COVID outbreak in the spring. And so they used their peer counselors and other WIC staff to make calls through FaceTime live stream daily to some of their mothers who were at high risk of postpartum depression. And they said this really made a huge difference in helping their moms feel connected during a time when they were feeling very isolated. If you're interested in learning more about some other solutions, I suggest you visit the CHEERS website that I mentioned earlier. We did a long-term series of weekly webinars on COVID and breastfeeding support throughout the entire spring, starting in March all the way through June. And they're all available for free as a download on the CHEER website. So you might want to take a look at them. One of the webinars that we did was a really great one. It was on the ways communities are getting involved. And we had some videos of various activities around the country, what people are doing. One of the ideas that we featured on that was an idea at my church that I'm a member of. My husband is a retired Methodist pastor, so we, right away after he retired, we found another Methodist church. It's just a phenomenal, inclusive church in downtown Gulfport. And they have this amazing array of outreach efforts using Zoom, Facebook live stream, and other technological means. But they have like a weekly check-in. It's called a mental health moment, where people who are suffering from isolation or other issues with fear related to COVID can get on that once a week and tune in and hear from a psychologist to hear more ideas on ways that they can deal with the feelings that they're experiencing. They have an event called Tuesdays with Tracy, where new parents can tune in and just get support with other new parents. I was a featured speaker on this live stream thing that they did one week. We talked about the importance of breastfeeding, and these live stream events are tuned into by thousands of people all over the country. So there's lots of options for ways to use virtual means to reach people. In Ohio, the Appalachian Breastfeeding Network takes calls 24/7. So the Department of Health provided a contract with the Appalachian Breastfeeding Network so that they could provide this service to the community. There's also a mobile app that a lot of states are using. It's called Pacify. In Mississippi, they provided access to this app for all mothers in Mississippi, whether they're on WIC or not, and they can tune in and get access through their phone with a lactation consultant. So there are so many phenomenal ways today of being able to reach new families. The bottom line, breastfeeding matters. The health and well-being of every single vulnerable newborn matters. How we support families matters. And although this COVID pandemic is a difficult time for all of us, we can find ways using the new landscape of support that we find ourselves in now to reach out to new parents and to show them that we care. My email is listed here. It is also in your handouts. And I want you to know I am always happy to receive emails from people who participate in my webinars and online offerings. I am here to help you succeed. So don't be bashful about reaching out to me if you have questions or you want more information about some of the things that I've talked about on this call. I'm more than happy to help you with that. So with that, I'll turn this back over to Rhonda so we can introduce the next speaker. Thank you all so much.
Thank you so much, Kathy. One thing I wanted to note for anybody that didn't see it in the chat box, the handout that Kathy was talking about, those will be sent with the video recordings as well. So everybody will receive that. And at this time, we are going to welcome Mr. Johnston and give him a moment to get his screen shared. Kathy, can you stop your screen sharing for me? Perfect.
All right, well, give me just a second to share my screen. I always have to remember to share my computer sound or else it won't work very well. All right, so everyone can see me. You know what, while I'm, so I guess you really can't see my picture while I'm talking, so it doesn't matter. Let's
If
jump
they
right into
select
this.
speaker view, they'll show you like in a little window as you're talking.
I gotcha. Okay, I was thinking about changing my virtual background, but I'll keep that beautiful screen behind me instead. It's
Looks
just kind
great.
of fun. All right, one little adjustment. There we go. Now you don't have to see my office all that much. So thank you for having me. I really appreciate being invited out to come. This is my favorite talk that I get to give, and I've given it, oh gosh, it feels like 1,000 times in the last 10 or 15 years. But I hope you'll enjoy it. Let's start with a little introduction who I am. By the way, those are the pitter-patter of little feet. All right, that just gets loud. So that is my crowning achievement of the things I've done in my life. Retired Army colonel, got my doctorate in nursing. What I'm most proud of is that group of folks right there. And I don't know if you can see my pointer, but that's me and my gorgeous wife Elizabeth there in the center. What's funny is most people when they meet her, they don't know her name is Elizabeth. They know her name is Gorgeous because I always call her Gorgeous. And they go, "Oh, you're gorgeous." And I go, "Yep, that's Gorgeous. That's her." And then directly beneath us is John. That's my oldest. He's in the blue jammies. Next to him is his lovely wife, Pamela. John is an Army officer. He's actually in Washington, D.C. right now, preparing for the inaugural parade. He's a personnel officer, and that's what he's doing. He's out in D.C. doing that. Hanging on my shoulder there is Jacob. He is a graphic designer, works for a Pentagon contractor. Interestingly enough, directly below Jacob, the guy in the Batman uniform, the one that's totally out of uniform with everyone else, is actually just John's friend from college who was single and stationed nearby and needed a home for Christmas. So he jumped in the Christmas photo after all. The one taking the picture over here on the right, that's Emily. She is a newly graduated degree in neuroscience, and she's working for the same defense contractor that Jake is working for. You'll see a picture of her at the end of the video too. Directly over my wife's head is Joel. He's a sophomore in college. He wants to be a surgeon, but he doesn't have the discipline for it. He'll probably end up being an Army officer after all. And then this chubby guy down here is no longer chubby. That's William. He's 17. Where's Nicholas over here next to Jake? He's 14. Timothy and Dorothy in the bottom there, the two in the babies there, that's 12 and 10. And that's my family. And so there aren't a lot of men and who are both midwives, lactation consultants, and fathers of 8 children. And so people always ask me what can fathers do, and I say, sit down, strap in, here we go. I'll tell you what fathers can do. Now I want to warn you. Being that I'm both a boy and I grew up a boy and I speak boy, I've spoken boy, it's my primary language. I speak boy very well, but I'm also a midwife and a lactation consultant, which means I've had to learn to speak girl along the way. And I will tell you that's made me kind of boylingual. Most of the time when I speak to people, I speak in girl talk because that's who I'm working with. But what I'm going to do today is I'm going to remove the mask that you are seeing, and I'm going to let you see what boys do when they're unsupervised and when we don't have to worry about making a good first impression. I'm going to teach you how to speak boy so that when you deal with fathers, both in the hospital and out of the hospital, and they say things that you consider rude or inappropriate, you'll understand why they are saying it. Okay. And so sometimes I get in trouble because the people who are listening to this conference or to this conversation don't always speak boy as fluently as they think they do, and they misunderstand what people are saying. So I'm going to show you several examples with my own language and several examples in video of what boys are like and try to explain it a little bit as we move through the process. So bear with me. These are the objectives. Okay, so no kidding, there I was. It was 1995, and young John, my firstborn, was about to be born, and I was just like Jim from The Office here. I was the most engaged father you had ever seen. And my wife had bought me this wonderful joke labor coaching kit, and it came with a giant yellow hat and a big sticker, a big patch on the hat with a guy going, yay, like that, holding a stopwatch. And it came with these flashcards, and on one side of the flashcard it said, "You're doing great, baby. I love you so much. I'm so proud of you." And on the other side, the flashcard would say, "You are now in first stage labor. Contractions are coming every 3 to 5 minutes. So you need to be doing this and that." And so I could throw these different flashcards up from time to time, and there was a message for her and a message for me. And I was the most prepared dad out there. Now, at the time, I was just an Army cook. I didn't have any nursing or any information that way. I was just a regular soldier, young. I think I was a specialist or a sergeant when John was born. And I was just a normal person. But I was so prepared. And then all of a sudden the baby was born and I was totally lost. I had no idea what to do. And the same thing happens to Jim. So Jim did the same thing all the way through the show. He's getting ready. He's putting diapers on everything. He's practicing being a father, and they're making lots of jokes. And then there's the first night in the hospital.
I don't know. I can't tell if she's getting anything.
Really?
It doesn't feel right.
Well, you're pushing the milk out, right?
How would one do that?
Wasn't it? It's kind of like that.
Do you want to try it, Jim?
Mm-mm. I think you're good. You're doing a good job.
There you go. And so there he is, totally unprepared, totally useless. And he calls on the nurse who, if you watch the episode, you know that nurse is just the worst nurse in postpartum history. She's just terrible, but that's what makes the show so funny. But here's what happens so often. How many times have you had this happen? You show up at an appointment or you go to someone's home and mom and baby are crying and dad is just jumping for joy. Yay, they're here, she's here, she'll help. Because they have been fighting and crying all night long with this screaming baby. And it is just a miserable, miserable feeling. And so my goal is to make it so this never happens again, so that when there is a problem, dad can solve the problem. Dad not only knows how to do it, or he's not only good at it, he can be trained how to do it, and he wants to do it. That's the most important thing. By the way, Kathy, if you're still listening, I would love to have that picture of the dad sitting there with everyone on their back turned to him, because we're going to talk about that later. So first, we have to understand that every infant requires as many loving and supportive adult caregivers as possible. The gender and biological relationship are not as important as what the adults can offer. This is important. So I use fathers because I'm a fatherhood expert, but what the baby needs is loving, caring supporters, whoever they are, right? I don't care if it's a dead dog's cousin's ex-college roommate, the baby needs help. Mom needs as much help as she can. I do fathers. But it's also important to understand that breastfeeding support personnel need to be prepared to address the concerns of all parents, not just the mother, but all parents. And I don't use the word dyad in my teaching. It's always triad or family, because nobody got here without having a mom and dad. We all have parents. We all have, egg and sperm had to come together. We haven't learned how to clone anybody just yet. So, but why do I use father specifically? Why don't I use other terms? Why don't I talk about other people? This is why. CDC data from 2014 showed that 64% of infants went home with married parents, and 24% were cohabitating, not married parents, which means 88% of all the newborns in America go home with married or cohabitating parents. Now, that doesn't say they're going to stay married for 50 years. It just says at the moment they are born, these parents live together 88% of the time. Now, I will tell you, the national average for C-sections in America is about 30 or 40%, which means only 70% of women experience a vaginal birth. Probably less than that, probably much less than that. And yet we still teach people how to care for vaginal birth and C-section. We don't say you can't talk about vaginal birth because not everybody has the vaginal birth. We say, okay, most people are going to have this. Let's talk about this first, and we'll talk about the other things separately or second. So that's why I talk about fathers. And what are fathers? Traditionally, fathers are thought of as these things: the moral compass, the disciplinarian, breadwinner, advocate. Now, these roles are changing, of course. But in my opinion, the most important role of the father is coach. He goes from labor coach to breastfeeding coach. He needs to stop being like Jim, and he needs to learn how to engage as an active parent in the relationship. Remember, fathers aren't breastfeeding support. Fathers are parents, just like the mother. We're going to talk about that in a minute. But this is how the media sees them as fathers. This is how we see fathers.
Diaper change. Thank you.
Oh my God.
The bottom
You can only see her face for a split second. I can't pause it in time to show you. But she turns and looks at him with this face like, oh, you fool. Look how cute you are. You're just such an idiot. And I always ask nurses in the hospital, if you saw a mother doing that when she was trying to change her baby's diaper, would you send her home with that baby, or would you call Child Protective Services? You would certainly get the social workers involved. But when dads act completely incompetent, we go, that's okay. He's going home with mom anyway. But, and so that is just totally unfair. Dads need to be held to the same standards as mothers. They made the baby. The baby is 50% their DNA. We need to engage with them and teach them how to be fathers. So let's talk, well, hold on a second. I'm going to get rid of this. There are no benefits to having a father, just like there are no benefits to breastfeeding. There are risks to not having a father, just like there are risks to not breastfeeding. If the Surgeon General can say there are risks to not breastfeeding, then by God, I can say there are risks to not having a father. We know that boys who are raised without their fathers have suffered from all these things. Poor infant weight, poor language skills, lower cognitive skills, decreased academic achievement, increased chance of being incarcerated, higher incidences of abuse and neglect, decreased empathy and social competence. Men who are children who are raised without their fathers have a detriment to their life. And President Obama talked about this a lot during his term, that when we raise children without fathers, the children take a hit, and that we need to engage fathers. So I can't engage outside the perinatal arena, but we need to engage every time we get the chance, welcoming fathers in. Now let's talk about breastfeeding specifically. We know that the #1 source of support for all new mothers, or for most new mothers, is fathers. That including fathers improves initiation, duration, and exclusivity. Over and over and over again, we've seen that in the research. This older study, Buckner and Matsumura, did a 5-point Likert scale and asked new mothers who was the most supportive person during their postpartum stay. And for those of you who may remember, Likert scales are usually from 1 to 5. So 2.5 is right dead center in the middle of this, from least helpful to most helpful. And what they found was the RN was #1 at 2.5. Not very helpful, but it was a long time ago. But still pretty darn, but the most helpful. And then IBLCs came a close second, which doesn't surprise me because, you know, IBLCs are only there for a few minutes, whereas the nurse is there all day long. So the nurse gets to engage multiple times with 4 or 5 couplets, where the IBCLC, you know, there's usually only one of them, and so they're all over the floor, and so they don't get to engage as often. But look at Dad, who has no training, no education, no specialty at all, right next to the IBCLC and the nurse. So dads are being helpful in the hospital, even though we think they're not. And the only thing that enhances continuation more than a father who is engaged is a baby who's helpful. They are the only ones who are more helpful than fathers when it comes to initiation, duration, and exclusivity. So what happens when we train fathers? WIC has done a few studies where they created a male peer counselor program where they trained fathers who were successful in breastfeeding to be breastfeeding peer counselors for other fathers. Stremler and Lavera did it in Wisconsin, Wolfberg did it in Texas, and they both found the same thing, that the initiation rate went up dramatically when you had fathers engaging with other fathers. The initiation rate went up really high. Now, the first randomized controlled trial on fathers was Piscani out in Italy back in 2005. And what they did is they randomized 2 groups. I believe it was 140 each. And one group, they gave standard education. The other group, they pulled the fathers aside for 2 40-minute classes on health promotion and basic breastfeeding troubleshooting. And what they found was that even though both groups had the same amount of breastfeeding problems, you see that they're the third from the bottom there, breastfeeding problems, 69% faced breastfeeding problems in the trained group and 64% in the untrained group. What they found was that in the trained group, interruptions due to problems was only 4%. That's impressive, only 4%. Now, I've been a lactation consultant for a long time, since 2001, maybe it's 2002, way back there, post 9/11 sometime. And I'll tell you that I can't boast a 96% success rate, okay? I am not that good, okay? But dads are. And look at this, relevant help from fathers, that fathers who are trained in breastfeeding, the mom said they were able to give relevant help 91% of the time. And that's not the only one. Australia, Maycock in Australia did another study, a much larger study, 699 couples, and they did a 2-hour breastfeeding class for dads. And what they found was the same thing. Now, Australia has a very high breastfeeding rate to begin with, but look what they found. That when you included fathers in breastfeeding, the rate of breastfeeding at 6 weeks was higher, the rate of formula feeding at 6 weeks was lower, and the odds ratio of being exclusively breastfed at 6 weeks was 1.46. So about 1.5 times more likely to be breastfeeding at 6 weeks, exclusively breastfeeding, if you taught fathers how to help with breastfeeding, okay? So what do we know? We know that dads increase initiation rates, they increase success rates, and most importantly, they solve our problems when they're at home at 3 a.m. And this is a big, big deal, okay? I always make a joke with my families. I can't go home with you. My wife gets very upset with me if I sleep at other people's houses. I have to stay home. So when you leave my office, you are on your own, Okay, and I need to prepare you to be on your own. At 3 a.m., you need to be able to take care of this. Okay, we also know that engaging fathers decreases the perception of inadequate milk supply. The only downside to this is that if we do this right, we won't need lactation consultants, okay? Because dads can solve the problem. That's the only downside. We'll work ourselves out of a job, which frankly, that's fine with me because I love lactation, but I can then, if I only have to take care of the few that don't need my help, then I can really engage in those preterm or NICU graduates, babies with congenital anomalies. I can engage with them and I can let dads take care of the rest. It's a fantastic idea for me. All right. Now, oftentimes we think that dads are not interested in breastfeeding. We think that dads are uncomfortable with breastfeeding. Let me just tell you, I'm going to squash that right there. Okay. I hate when people say, I'm uncomfortable with that. I don't care. Do you ask mom if she's uncomfortable with changing diapers, or do you ask mom if she's uncomfortable with breastfeeding? No. You just put the baby to the breast, the baby goes to the breast. And people use they're uncomfortable as the worst excuse ever. So I don't listen to that nonsense. But the reality is that dads are absolutely not uncomfortable and that they do want to help. Now, these researchers did a study, and it was a phenomenologic study, and they interviewed postpartum couples about their experiences in the mother-baby unit. And what they found was they identified 289 critical incidences where fathers were talking about postpartum experiences. Most of them, by the way, were negative experiences. Now, what's really interesting is they did this after only 13 couples, okay? 13 couples in 48 hours identified 289 critical incidents, mostly negative, in the postpartum unit. This was pretty darn impressive, okay? The number one concern of new fathers was that they felt that most of their negative experiences were that they were ignored by nurses. And here's a quote from the study. I wasn't excluded by the nurse. They didn't ask me to leave the room, but it was the nonverbal exclusion by how they held it, how their body was. They never asked me how I felt as a dad. And Kathy had that amazing picture with the nurses all clustered around mom, completely turning their back to dad. Right. And I saw the same thing when I came back here to Fort Bragg. I've been stationed at Fort Bragg 3 times. I was here as a lieutenant. I was here as a captain, got promoted to major. I was here as a major, got promoted to colonel. I spent a lot of time in Fort Bragg. And when I came back to Fort Bragg on my last assignment, they asked me to do a competency evaluation of the lactation consultants to make sure that they knew what they were doing. Because, you know, the chief nurse of maternal child didn't have the foggiest idea what lactation consultants did for a living. So she couldn't do the competency evaluation. She needed another lactation consultant, an objective third party. And so I went and I did my competency evaluation. And they were pretty good, but every single time, all 3 lactation consultants, when they entered the room, they stood between the mother and the father and turned their back on the father every single time, just like in that picture. They completely ignored fathers every single time they walked in the room. So what do dads want? Nurses believe that fathers are uncomfortable, that they're uninterested. But if you think about that picture, you saw what Kathy showed, that they weren't uninterested at all. They were ignored. They were told to sit quiet and sit in the corner and don't bother us, is what they were being told. Fathers overwhelmingly expressed motivation to be noticed and deplored the fact that they were not being addressed by the nurses over and over and over again, because they were being treated as just the husband. Now, let me tell you a fun story. So, so as I mentioned, I was at Fort Bragg for 3 different assignments, from lieutenant all the way up through colonel. I spent a lot of time in Fort Bragg at their hospital because it's the biggest maternal child hospital in the Department of Defense. It's enormous and it's all babies. Okay. And so I was there. I had a few babies there, right? I think, let's see here, number 5, 6, and 7 were all born at Womack Army Medical Center. And so when number 7 was being born, I'm pretty sure it was number 7. Could have been number 6, but it was probably number 7. It was Timmy, Tiny Tim. when he was being born, we were, this is our seventh time in this. We knew we didn't have a lot of time when labor started, so we were going to get there early. So we got there a little bit early. It was, late evening, maybe 8, 9 o'clock, and we were, and as always, labor and delivery was just hopping busy, and so we showed up, and they put us in triage, and a few minutes went by, and we were just kind of sitting around waiting for things. We weren't in active labor because a G7, P7 doesn't stay in active labor for more than like 3 minutes. So we didn't want to be in active labor. So we were there pretty early, and we're reading our books. And after about 20 minutes of waiting for the nurse to come in, I thought, you know what? I know what I'm doing. So I went and I hooked her up on the monitor. I took her vitals. I filled out her triage sheet. I got everything ready, and I was ready to go. And then I sat back down. So here we are, sitting down waiting. And finally, after about half an hour, in comes old Joyce. Now, I love old Joyce, but Joyce, when I call her old Joyce because she's old, okay? Joyce, I think, was there at the birth of Christ. I'm absolutely sure of it. And so she retired in the 80s from the Army as a senior non-commissioned officer. And here we are 20 years later, she was old, okay? And she moved like somebody who had been a nurse for 400 years. And so Joyce comes in the room, just barely moving, and she finally gets to us, and she picks up the clipboard, and she says, "Hello, Mrs. Johnston. It looks like you're here in labor." And then, well, honey, who hooked you up? And my wife pointed at me and said, "He did." And so she turned and she looked at me. She made eye contact with me, and she went, and then right back to my wife again and said, "So what brings you to see us tonight?" And my wife said, "Stop. Do you recognize him?" And she turned and looked and went, "Oh, Colonel Johnston, I thought you were just the husband." And I said, "Yep, I'm just the husband. And I've done all your work. You can just turn around and go find me somebody who can do the admission. Thank you very much." I was so upset because if she treats me, the chief of all midwives in this facility, who has worked with her for 15 years, as just the husband, what does she do to strangers? How does she treat people she's never met? Right? And it was just another sign that they were not listening to what I was trying to show. So 63% of the fathers felt that nurses didn't give enough information. 29% of the negative influences or experiences were about breastfeeding. Understand, fathers are very confused about breastfeeding. They're very curious about breastfeeding. They want to know what's going on. And they said things like, "Breastfeeding was what I found was most difficult. I didn't know how to help. I felt useless." Now, let me tell you something, folks. If you want to emasculate a man, you want to shut him down and ruin him for a long time, make him feel useless. You all know men, we hate being useless. You tell me the screen door is making a noise, I'm going to go fix it. You tell me that there's something, you got a problem, I'm going to address your problem. I don't want to sit and talk about your feelings. I don't care how you feel about the screen door making a noise. Tell me it needs to be fixed, and I'll go fix it because I want to be useful. Don't let me be useless. Men hate being useless. We hate it. So when a father says, "I felt useless," at the most important time in his life, when his child has been born, that's a big deal when a father feels useless. You saw Jim feeling useless. I've told the story about feeling useless. It is a big deal to feel useless. It's not necessary because we're really helpful. The other one that a lot of fathers said was, it's hard to become totally involved when you can't feed him. And this, apart from sleeping, is predominantly what he's doing. And I love when dads say that because that is a giant opening. I can drive a Mack truck through that argument because I tell them, I agree. He eats a lot and he sleeps a lot. But understand, he's only eating for about 8 hours a day, okay? 10, 20-minute feedings doesn't take up too much time. 10-hour-long feedings only takes up 10 hours. That means he spends the other 14 hours a day wanting to be loved on by people while he's not eating. That, you know what? You can love your baby and hold your baby even if you don't have breasts. You can hold and love that baby even if milk isn't squirting from your chest. You have plenty of time. And if 14 hours a day, you get most of the day. If 14 hours a day isn't enough time for you, then you've got attention-seeking problems, and we're going to have to get you referred to mental health because there's something wrong with you. But what it is we feel like if a baby's sleeping, he doesn't need anybody, which is absolute nonsense. Anybody who's ever had a newborn knows that as soon as you put them down, they wake right up because babies are never designed to be put down. So it's the same reason I say parents don't ever need to be tired, because baby sleeps 14 hours a day. If 14 hours a day isn't enough sleep time for you, there's something wrong with you. Okay. The problem is that we don't take advantage of sleep time. We think sleep time is wasted time, and it is not. Sleep time is useful time. So I always take advantage of dads when they say they feel useless, and I snag them and I say, nope, you're useful. Let me show you what you can do. Mom feeds the baby, you help mom feed the baby, and then you immediately take the baby and love on the baby until he needs to be fed again, if mom will give him up. Okay. So let me show you a great example of dads being totally unfiltered. Okay. I've talked about how dads are different from moms. Where did it go? Where did it go? Is it here? No, it's not here. I know I opened this up. Here, it's got to be here. There it is. All right. I can't play this directly from the video, from the slideshow over Zoom. That has something to do with YouTube.
No, then she got going
Watch
to the
this.
doctor. She gonna be peaceful. Well, I ain't gonna be peaceful with you.
This is a young father helping his newborn son get his first immunization.
Champ, man, you know. So you won.
Boy.
You gonna be all right. You keep looking at me. There you go. Look at me. You gonna stay strong.
I assume that's
strong,
oral
man.
polio vaccine.
No more.
Stay strong. Okay, look at me. You gotta look at nobody else. Look at me. Now, you get now. Come on now. We gotta do good. Look now. Now we finna get these shots. Look at me now. They take. They be all. You gonna be good. I know you gonna cry, but it's okay to cry. It'll be okay. It's okay to cry.
You can't see
Come on, get
anything
these
but
shot
that.
right quick so we gonna get our way. So I can hear you scream and cry when you're in the car. I know you gonna be hot. You gonna be all right.
Lay 'em on the table for me, Quan.
Uh-oh, here we go. You ready? Come on.
By the way, mom is in the room, but she,
now you got look. Now look. Now it's gonna be like, oh, I got your hand. I got you. Dad, hold on, see. I got you. Damn, you strong, boy. I got you.
All right, Pumpkin.
Oh,
Nice
Lord.
and
Hold on.
easy.
Oh, Lord. Oh, man. Come on, man. I feel you, man. Come on, man. Daddy, look. Come on, they go.
Are you videotaping this?
Man, I know. Man, I know it, man. Man, I know it, man. I'm sorry. Man, I know it, man. Look at Daddy. You gotta look at Daddy. You gotta look at Daddy. Oh, man. I know she's thinking you got it any kind of way, man. Come on, man. I know it. Oh, mama. Daddy know it. Daddy know it.
Those are too big, and he's not gonna do
Daddy
it.
know it.
One more, Pumpkin. One more.
Oh, Lord. I know it. 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 I know it, man. Please. I know it. I know. Come on, Dad. Come on.
See that on
Come on, man. Come on, man. Come on. I know. They did you wrong. They did you wrong, man. I know. I know. They did you wrong. I know. You need to explain to Dad. Yeah. What she did to you? She did. She started to you. It hurt. Okay, we calm down. Okay. Daddy, you know, told him Daddy gonna be him. Well, you strong though. You strong.
sweet is that. Now, I'm telling you, I could probably write an entire doctoral dissertation on that one video about fathers and how they communicate with their children and that kind of thing. What you saw was a father being totally unfiltered, being himself, not afraid to be himself, and working with his son. Talk about how you're strong and you're going to be okay, and I'm going to be here for you, and being loud and obnoxious. And why was he being loud, obnoxious, and funny? Because he was frightened. That's why. Because he was worried. When men get worried and frightened, they get obnoxious and loud. Okay, a great story. So in the Army, we have a lot of dads who are deployed. You may not know this, but for the last 20 years, we've been at war. And so a lot of dads make babies and then they go off to war and then they leave their families behind while the babies are born. And so dads can't be there at birth. And so what happens is every day, soldiers are given the opportunity to FaceTime with their family for 15 minutes. And, you know, the whole platoon takes 15 minutes. And so they have time to write back. And so when a baby is being born, the platoon or the company will donate all of their time so that dad can be there for the birth. And so he gets 4 hours, 8 hours, 12 hours, however much time his platoon can donate. And so it's really common to labor with a mom and have dad there on a computer talking while we're laboring as though he's in the room. And one day I was in Fort Drum, New York, and we were having a baby, and everything was great. And mom was there, dad was there, everyone was happy. And then baby started to have some heart rate problems. And so, we're turning mom over, flipping left and right. We're turning on the oxygen, bolusing fluids, doing all the things you do in labor and delivery. And all of a sudden, and mom one time rolled over and turned her backside to the camera while she was rolling over. And out of the corner of the room, I hear, "Jesus Christ, I just saw the acid trigger." And the whole room fell silent. We couldn't believe we had heard that from the back of the room. And it occurred to me, oh my goodness, I have forgotten dad. And dad is frightened. What's happening to my wife and my baby? What is all this going on? And you haven't told me anything. And he needed to get our attention. And so he made an inappropriate joke to cut the tension and to get attention on him so he could then be explained what would happen. And I said, "Oh, Dad, I'm sorry. I forgot all about it." Mom was laughing. She called him an ass, and we went on with our day. But it was a warning to me, that it was a reminder that I had ignored somebody in the room, that I needed to engage with him and warn him. So you'll hear that a lot from dads. They say inappropriate things. They make jokes at the wrong moment. And because the average woman would never do that, they don't understand it. But what dad is saying is, "I'm frightened. Please explain to me what's happening." Okay, that's the language that he's choosing to use because he speaks boy. Okay, so Rempel and Rempel, I assume they're a husband and wife team. I've never met them. They interviewed 21 breastfeeding fathers, and they said, what is it about breastfeeding that fathers need to know? And what they found was that all of the breastfeeding fathers used sports analogies to describe breastfeeding. They all talked about how we're a team, where this is like beach volleyball, where you've got two people on the team and one is strong and one is weak, and they play off each other's strengths and weaknesses. Some are good spikers, others are good setters. Or they use a football analogy: I'm the defense, she's the offense. Or they use baseball about hitting home runs and that kind of thing. But all the fathers use sports analogies. That all the fathers in the study valued perinatal education that they received, and they enjoyed being breastfeeding savvy. You all know that guy who is a car expert or a baseball expert or a tool expert, and he loves to show you his knowledge in those things. And he's like, Satchel Paige paid second base for the Brooklyn Dodgers back in 1922. And you're like, who cares, right? Men enjoy being the subject matter expert, and fathers who were trained in breastfeeding took personal value in being breastfeeding savvy and sharing that information with other fathers. They loved to show the other dads they knew about breastfeeding, that they valued the breastfeeding mother as beautiful, wonderful, important, someone that needed to be supported, and that they were all able to facilitate breastfeeding. Okay. They did report jealousy. They said that one of the things that bothered them was that mom got to spend so much time breastfeeding the baby and they didn't get to spend enough time. And like I said, this is where we can engage with them and we can get them bonding in the feeding zone. We can get dads taking advantage of the time to help with latching, to help with positioning, to make sure that mom's life is supported, and to take care of the baby as soon as the baby comes off the breast. Now, in my family, it is my job to put the babies to bed. So mom feeds the baby, and when baby's old enough to sleep without mom, then I take the baby and I put the baby to bed. I'm a huge fan of co-sleeping. I've written a couple articles on it. I love co-sleeping. I love it. I support it 100%. But my job was always to put the baby to bed because, of course, I don't have milk leaking from my breast. I can't feed the baby, and mom needs to rest. So I'll put the baby to bed while mom takes a nap. And every baby has their own lullaby, each one. Number one, it's a Billy Joel song. Number two, it's John Lennon. Number three, it's another Billy Joel song. Number four is the lullaby from the Prince of Egypt. Number five is a poem about the fifth child called Ode to the Fifth Child that I set to music. And it sings, it's set to the same tune as the Prince of Egypt. Number six is, I'm blanking on number six. Number seven is the song from Dumbo, Baby Mine. And number 8 is Mary Poppins, the Stay Awake. And so every baby has their own lullaby, and I sing it to the baby until either the baby or I fall asleep every single night. And that's my special time with baby. And what's really fun is fast forward 10, 15 years, if the kids hear their lullaby come on, even though they haven't heard it since they were 2 or 3, they know their lullaby. They know that's their lullaby. And they'll be when baby number 1 was little, his lullaby came on the radio and he started crying because he didn't want to go to bed. We had to turn the music off because it wasn't time to hear that song. So they engage, they remember that their entire lives. All of my children, you ask them their favorite song, they'll tell you it's that song, and they don't even really realize that it's their lullaby when they hear it. But fathers are important for, singing, playing, bathing, bedtime rituals, that sort of thing. Fast forward a few years, the Rempel team joined in with more, and they created a partner breastfeeding influence scale from their work. And they found that fathers help in 5 ways: by being breastfeeding savvy, by being helpful with direct, tangible support, by showing appreciation, by being a breastfeeding presence, where fathers assisted during breastfeeding, not just with the breastfeeding, but with other things in life. Like, it was always my job to cut my wife's meat for her when we ate dinner, because she was always breastfeeding the baby and only had one hand to eat. So I would cut her meal for her and make it ready for her to eat and serve the drinks and all that stuff, so that she was always supportive. And the responsiveness, the fathers were sensitive to mother's needs. What they actually found was that knowledge was less important than responsiveness. That responsiveness and presence were the most helpful of all the things that dad can do. And that breastfeeding savvy was a little bit off-putting sometimes, where dads were sometimes not sufficiently sensitive to their partner's needs. And they would say, well, come on, we agreed we're going to breastfeed, let's breastfeed. And so being the breastfeeding savvy dad was less valuable than the dad who was responsive to mom's needs. And they found that non-directive cooperation and invisible support provided more assistance to mothers. So the idea was that mom and dad work as a team with shared goals and shared support of each other as they move through the process. And if the goals changed, then they changed and they moved on, but they moved on together as a team. Now, Cindy Dennis did some work with Abbas Dick to create paternal self-efficacy studies, and they found that dads who had higher self-efficacy, dads who said, I can always help mom with whatever, were more likely to have successful breastfeeding at 6 weeks and exclusive breastfeeding at 12 weeks. And that they used co-parenting techniques to enhance self-efficacy. So what is co-parenting, you ask? Well, I'm glad you asked. Here is co-parenting. So they created a theory called the co-parenting theory in breastfeeding. And they said it consists of 5 things. Joint breastfeeding goals. Not he wants her to breastfeed for 2 years and she wants to breastfeed for 2 months, but shared goals they came up with together. Shared responsibility. It's not, here's your baby, I'm going to go play golf. It's shared responsibility. Mom and dad work together on the breastfeeding care. Proactive breastfeeding support, looking for problems, troubleshooting, that sort of thing. Parental-child interaction with the father as a parent, not as a support person, okay? The father is equally important in co-parenting theory as the mother is. And productive communication and problem-solving skills, that they taught moms and dads how to communicate better their needs and their wants and their fears and their worries. They then did they did a study where they did, this is really amazing, 1 15-minute inpatient intervention in the hospital, where they go over those 5 components. They gave them workbooks and videos and followed up with them and sent them on their way. So in 15 minutes, remember, Maycock was a 2-hour intervention and Abbas Dick was 2 40-minute interventions. This was 15 minutes in the hospital. And what they found was that father's self-efficacy scores went up, that they were significantly more likely to offer supportive help, and that moms were more happy having dads who were using co-parenting theory over the others. Interestingly enough, they did a follow-up study and they found that this is what parents want to know. So listen to this, that breastfeeding is not always easy and parents need to know that, okay? That it's not this field of roses that every once in a while it's difficult. As a matter of fact, research shows 80% of new mothers or new parents struggle with breastfeeding in the first 2 weeks. 80%. So they need to know that it can be difficult. By the way, that this is another talk, but when it's difficult, it's our problem. Our healthcare providers are being stupid. So that there's guilt when breastfeeding doesn't work. That fathers liked the discussion that was happening in the hospital, but moms had no time for it. Moms wanted the book and the stuff that they could use outside the hospital. That makes sense. Moms are a little distracted in the first 48 hours postpartum, okay? And the fathers wanted to be treated as a support, or wanted to be treated as a parent, not as a support person, okay? So people always ask how I teach dads. Let me show you how I teach dads. First, if you're going to engage fathers, you have to have evening or weekend clinic hours. You can't work Monday through Friday, 7 to 3. You've got to get time when people, you got to allow people who work to come to the appointments, right? So you have to have evening and weekend. Focus on dad's perspective. Ask dad what he thinks and take it seriously. How often do you have people say where mom will say one thing and dad will say the other thing, and you just totally ignore what dad says because mom knows what she's doing because mom is the one who's breastfeeding? Moms, unfortunately, they don't always see what they think they see. I'm an athlete. Well, I was an athlete. As you can tell now, I'm an old fat man. But when I was a kid, I was an athlete, and I was one of the best butterflyers in California back in the 1980s. I was fast, okay? And as an adult, I went back into swimming, and in my head, I still look like Michael Phelps. I'm doing perfect. I'm reaching, I'm extending, I'm doing everything perfect. But my coach was like, "Oh my God, you have a terrible butterfly. What is wrong with you?" And I'm like, no, it's perfect. Look, I am reaching out. She videotaped me, and I said, "Oh my God, who's that fat guy, rolling around drowning in the pool?" It was me, and I couldn't see it. So moms are the same way. They need a coach. They need somebody who's objective, looking from the outside in. So listen to dads. When you talk to dads, talk about the value of breastfeeding, not the emotional aspects of breastfeeding, the value of breastfeeding. How much does it cost? How healthy will it make people? Why is it a good thing to do? Don't talk about love and bonding and isn't it pretty, and avoid the use of pastel colors. Stay away from pink and yellow. Stay away from those. Give earth tones if you're going to talk to dad. Greens, browns, blacks. Use darker colors. Dads appreciate earth tones, okay? Give them tangible things. How do you position the baby? How do you latch the baby? How do you fix a bad latch? Measurable signs, signs of milk transfer, satisfaction, weight gain expectations. It's really, really important. And there's some evidence out there that shows that male-specific single-sex programs tends to work better. So having men teach men tends to work better. And you've all seen it, right? Because I've watched women try to teach men breastfeeding. And when women try to teach men breastfeeding, they use the exact same thing they say to women. And men are like, "I have no idea what you're saying. You're not speaking my language. I don't want to hear about bonding and beauty and all this. Don't tell me how I feel. I don't want to feel. I want to do. I want to fix. I want to use things," right? And this is what Sheriff and Patton had to say from fathers, that it has to be, this is a dad's quote, "It has to be clear and specific to fathers. Otherwise, I would just dismiss it as yet another health leaflet. If it's aimed at dad, then I'll take a look. If it's just among the other stuff, it becomes saturated, and I don't want to have to sift through volumes in order to find the information," right? Dads want something that looks like it goes to dad. I'll give you some examples. There are 3 programs I'm going to talk about. One, actually, 2, I think. Anyway, one is this site from Canada. They use a car analogy, and they say that babies are like cars. And so their website is 24-hour cribside assistance, okay? And here's one of the videos where they talk about how babies are like cars. But they talk about fuel consumption, performance, exhaust, maintenance, that kind of stuff. I'm only going to play a little bit of it.
I'll tell you, babies are like cars. They all have their own quirks, and I've had a lot of old beaters that you have to start the right way. You got to turn the key, press the gas, pump it, and then and babies are kind of the same way. Once you figure out what their little quirks are and what their little intricacies are that make them work, then you're good to go.
Let's consider designing an automobile.
If you're going to go buy a car, and you know that this car is going to be with you for a long time, You know, you've got at least 18 years with this car. You know, you're going to want to know stuff about that car.
About 40 years ago in North America, the percentage of men present at the birth of their children was
you can
about
watch
0.
this video on your own. It's free online. It's fantastic. And they have several videos where they talk about how breastfeeding is fuel consumption and exhaust and performance and all that stuff. They really are very good. They have sections for the First Nation population in Canada, and lots of ways to reach out to outside the majority population as well. Now, Cleveland hospitals, or University Hospitals of Cleveland, came up with this program called Breast for Success, and this is meant specifically for the inner city population of Cleveland. It was aimed predominantly at communities of color. And in this Breast for Success program, they developed a separate one called Dads to You. And Dads to You was taught by community leaders in the area who were men, and they were teaching other men. They were acting as peer support for the other men. And if you want it, the link is right there for you to look at. Here's some examples. And I want you to notice this. Is this what you think when you think about breastfeeding handouts? Is this what your breastfeeding handouts look like? Absolutely not. These are what Dad's breastfeeding handouts look like. Notice the colors. Notice that it's sepia, gray, black and white, dark, earth tones. Look at this checklist on the right. How boring is that? Because that's what men want to see. They want a clear-cut checklist. These are the 7 things I need to know, and here's who I call if I have problems. This is fantastic. This is specifically for dads, okay? This is what we want to see when we're looking for help, okay? We want to use father-specific language. Don't bother telling dad to change the diapers. It's not fair that mom gets the head and I get the butt, okay? I want to know how to love my baby. I don't want to know how to perform maintenance on my baby. I want to know how to love my baby. I want to know that I can cuddle him and how much I can throw him around before I break him. I want to know these things, right? Because I'm military, I use military analogies, and I always say, Dad, it is your duty to stand guard over your family and to protect them against the things that are going to come in. You need to be prepared when they have problems to support them and make them better. You need to be able to protect them from all those visitors who are going to come and steal their sleep time and shoo them away. In my house, when we have a baby, if you're going to come over and visit, you have to either do chores or bring food. You're not allowed. My babies are not animals at the zoo. You're not here to look at my baby. You're here to work, okay? Mom and I will take care of all the looking and caring for the baby. If you're going to come over and see the baby, you better bring yourself a casserole or something, because there's a price for admission. I always teach dads that moms are superheroes. Dads love superheroes. I always teach the dads that moms are superheroes, that mom is like Wonder Woman. She has amazing superhuman abilities that men don't have. If dad is a superhero, he's Batman, okay? He has no superpowers, but he has a really cool tool belt. It's his Adam's apple. When a dad talks, his voice vibrates in his chest, and it's a full body massage for baby. So I say, if baby's not hungry, give him to dad and let dad talk and go, hey baby, how you doing? And sing a little song, and baby will bury in the chest, go, oh, where have you been? This feels so good. We know rhythmic and vibrating is very soothing for newborns. So use dad's tool belt, okay? Encourage dads to talk about how beautiful and wonderful mom is. Encourage them, because mom needs to hear it. Here's an example of, again, unfiltered father behavior.
You awake?
Yeah, of course I'm awake.
Notice the broken
Is that a new
arm.
mask?
Oh, yeah.
I love it. It's really creepy.
I know, right?
Yeah, good stuff.
Thanks.
Hey, let me introduce myself. My name is, and proud of it, and all dads should be.
Why? You know why. Kids think we're awesome. We get our hands messy. We tell hilarious jokes. Hey, Nolan, we gotta get up, buddy.
Big lazy.
We never say no to dress up. We build the best forts. We do work, and we do homework. We lead by example. We blow their minds.
Can't believe he's his father.
I know, that is called a plot twist. Being awesome isn't about breaking rules, it's about making them. Hot stuff coming through. Wife and the coffee.
Got a compliment.
And breakfast is for breakfast. Hey, Nolan, give me a look here. Suggestion, that's a boy, that's a man. But it's also for lunch, dinner, and midnight snacks. Scrape knees, These aren't boo-boos, they are badges of bravery on the playground. Hey, Victoria, that profile pic? Awesome. When you're a dad, hugs can be bear hugs, but they can also be high fives, fist bumps, and next level handshakes. Kids, they're our best friends. They're our greatest fans. Buddy, you've been gaining muscle mass, nice. And they look to us like the same way we look at superheroes, up, because we're taller. Now, dadhood isn't always easy. When a rule is broken, we're the enforcement. Hey, buddy, it's garbage day. But when a heart is broken, we're the reinforcement. And we wouldn't have it any other way, because being a dad is awesome. Just like new peanut butter Cheerios are awesome. That's why it's the official cereal of dadhood. And this, my friends, this has had a dad.
Now, I allow the shameless product placement of this commercial because I think they did a great job making this video. It really shows fatherhood from several different perspectives. But also, if you do a Google search for #HowToDad, you can go to the Cheerios website where they have all kinds of father-specific graphics and posters and things that you can use for your dad. You can use templates and stuff like that that Peanut Butter Cheerios has made for you. So use their stuff, okay? Everything he did was appropriate from the eyes of a father, even throwing the 12-year-old kid across the room with a broken arm, perfectly acceptable, okay? Fathers teach by destabilizing, where mothers tend to teach by loving and caring. Fathers teach by destabilizing. We are perfectly okay with throwing them around. It's okay. It's part of the playful nature of men, okay? So in my teachings, these are some of the slides I use from my dads. You made this baby. It's your job to go from labor coach to breastfeeding coach. Support, support, support. They need your help, and you're going to make this happen, okay? That it takes two to make a baby for a reason. They are hard dang work, okay? Every mom needs somebody to help her, and so that's why there's a man and a woman involved in every child, because they each bring their own skills to the table. They each bring their own unique way of doing things. It's kind of like a yin and a yang thing. You know, you got your pluses and your minuses, and you create a well-balanced person. The couple principle. You know, when you look at your husband and you just give him that death look and he knows to shut up, okay? That's because you guys have mastered nonverbal communication. And moms and dads communicate without needing to talk. And they know each other much better than I do. He knows what to say to help and to harm. He knows what not to say, okay? And so he's better at working with her than we can be. So if I need to teach him so he can take that lifetime of experience and use it to get the best results for his family. And the dads have enormous pull over raising their baby. When dads say, yes, I'm support this 100%, go with it, then they're likely to go with it, right? How can a mom breastfeed when dad says, ew, you're doing that again? Yuck. How do you know he's getting enough milk? You can't, right? So tell dads that they need to be involved in it and they need to support it. I talk about myths. Men believe that breastfeeding is woman's work. I say, no, it's not. Look at me. I'm a woman. I'm not a woman. I could do it, right? That mom needs a break from feeding at night. I love this. This is one of my favorites. When baby number 1 was born, I was an Army cook. My wife was a neonatal intensive care nurse. So her job was more important than mine. We were both active duty soldiers. She needed to sleep. I didn't. So when she was going to go back to work, I was going to do the 3 a.m. feeding. So here we go, the first 3 a.m. feeding. I wasn't even asleep. I was laying in bed, pretending to be asleep, waiting for John to make a noise. And as soon as he went, meh, I jumped out of bed and I snatched him up and I ran downstairs where I set up we had the pumped milk and I, defrosted the milk, got it all set up in a bottle. And I thought, well, there's no reason for me to sit down here. I've got a rocking chair upstairs. I'll go up there and sit in a rocking chair. So I went upstairs and there's my wife, wide awake, lights on, pumping. And I was like, what are you doing awake? You're supposed to be sleeping. And she said, I couldn't sleep. I heard him when he woke up. You weren't fast enough. There's no way. And then you went downstairs. You sounded like an elephant down there in the room, making all that noise, warming up the bottle. And then you came upstairs and my breasts are full. I couldn't sleep. Have you ever tried to sleep with a full bladder? It can't be done. So she needed to pump because it was time for baby to eat. And so I said, this is just stupid. There's no reason for both of us to be awake. I'm going back to bed. Here, you take the baby. I'm going back to bed, and I'll give you a nap tomorrow, I promise. And that's the way, and then we started working on that. So moms can't sleep through a feeding, but dad can encourage mom to take naps during the day. I tell a mom, I don't care if it's only 15 minutes. Close your eyes and take a nap. What moms tend to do is go, it's not worth it. It's only an hour. What good's that going to do? I go, it's worth it. Go to bed. And so they need a coach to remind them to sleep during the day as much as possible because they can't sleep through a feeding. That's just silly. Men think that breastfeeding makes the breast sag. Breastfeeding doesn't make the breast sag. Genetics make the breast sag. And I tell my dads, if you want to know if mom's going to have saggy breasts, go ask her mother if she has saggy breasts. Her mother's saggy breasts will tell you what her saggy breasts are going to look like. Okay, it's genetics. It's not breastfeeding. It's not pregnancy. That's just life. Okay, and that breastfeeding is not natural. I've actually had people tell me that. I'm like, really? You're not a mammal? How does that work? Do you know what a mammal means? You know, but it's just because they were raised in a formula feeding environment. They believe that breastfeeding interferes with their chance to bond with baby, and I feel like I've talked about that enough. But know that that is one of the #1 concerns of engaged fathers, is that they want to be helpful, they want to bond with their baby. So I teach them about singing lullabies and all that other stuff. Tell them they need to learn about the baby and not be afraid. Okay, I feel like I'm kind of running short on time and I want to get to the end. Now, remember I said that dads are simple. We need concrete tools. So teach them 3 things. When does my baby eat? How does my baby eat? When is my baby finished eating? That's what they need to know. When does he need to eat? All the time, every 2 or 3 hours. How does he eat? I always say, Dad, there are 19 components of a good latch. Don't bother trying to memorize them. This is what a good latch looks like. Okay, what would you look like if you tried to put the whole breast in your mouth at the same time? You'd look like this, and that's a good latch. Okay, and when is he finished eating? When he's finished eating, his hands are going to relax. He's going to pull away from the breast, and he's going to be all milk drunk, and he's going to, that's when he's finished eating. If he's not doing that, he's not finished eating. Get him back to the breast. Okay, so the simple things. Now, remember I said dads like analogies, and I'm a soldier, so all of my analogies are about war and combat and that kind of stuff. My pointer is a bullet. I have a sword hanging on the wall in my office. It's all about being a warrior. So believe it or not, if you've ever been in the military, you are a breastfeeding expert, because the Army teaches breastfeeding. So does the Air Force, so does the Navy. They all teach breastfeeding in basic training. We call it basic rifle marksmanship. Breastfeeding a baby and firing an M16 is exactly the same thing. All you got to do is line up your front and rear sight posts, and if there's a problem, you pull on your charging handle. That'll solve your problem almost every time. And we teach all soldiers sports: slap, pull, observe, release, tap, shoot. Slap, put your hands on baby's back, press them toward the breast. Pull, reach in between the chin and breast, grab a charging handle, pull on his charging handle. Observe, do the cheeks puff out, his jaw open up, his pain go away. Release, let him go and let him suck again. Tap, try again. If it doesn't work after 3 or 4 taps, then shoot, you got a hopeless double feed. You're going to drop your magazine, clear the chamber, reload, put that sucker back together again. And when I'm talking to just dads, I use another 4-letter S word instead of shoot. It works really well, okay? But if dad's not military, you can say, well, you know about sports, right? Sports, slap, pull, observe, release, tap, shoot. And my friends like support instead of slap, but I like slap. It works better for dads. So just for fun, I included the handout. This is the one I give dads. It's got all that on there. You guys can have it. I'll send you a copy of it if you want. But I love the get to the chopper for the baby. It cracks me up. But this is how sports and breastfeeding are the same thing. Okay. Want to see my boobies? Boo. When you're talking to dads, you have to make jokes. And jokes about sex work better than any other joke. Trust me. Make jokes. They appreciate a little humor to break the ice, to bring up uncomfortable situations. So here's a problem. Men are physical, sexual creatures. We are. There's a lot of research out there talking about how men think about sex like 200 times a day. We do. I'm just going to let you know. We do. Okay, all the time. Okay, it's distracting and it's frustrating, but it is. Okay, we do. So if you're going to talk about a new mother, you have to talk about sex. You just have to. Unfortunately, women, not so much, especially in the first couple of weeks postpartum, not terribly as interested as men are, okay? Now, dads suffer because of the Madonna complex. She's a mother now. I can't do that to her. She's a mother, right? And she's always holding the baby. What am I supposed to do, right? Which always makes me ask, can you get pregnant while you're breastfeeding? You can, of course, but you should put the baby down first. That's a good idea. Don't get pregnant while you're holding the baby. But men need to know that mom just might not be into him all that much. Mom is distracted. Mom has more important things in her life. Some women have an increased libido thanks to prolactin. Other women have a decreased libido thanks to oxytocin. I'm sorry, the other way around. And that's just the way it is, right? That it might not be, high on her priority list. All breastfeeding women, or almost all breastfeeding women, suffer vaginal dryness. So we have to talk about, increasing lubrication and foreplay. And women are just all touched out. Being a breastfeeding mom with a newborn is a demanding physical job, which always reminds me to tell your dads, you got to give a little to get a little, okay? And he who vacuums gets more attention at night. If dad can encourage rest and relaxation during the day and take away some of mom's stress, dad's much more likely to have a mom who's interested in him at night, okay? If my wife is just exhausted after a long day, I know not to ask for sex. It's just not going to happen, right? So if dads want sex, they have to do the work during the day. They have to plant those seeds and work during the day to make it so mom has the energy to care for them at night, because they are tired, they are tired. So let mom get some rest during the day and work for her during the day. And, men are never too tired, by the way. We're never too tired. We don't get headaches. We're like, I'm all over it. Let's just go. Okay. But moms tend to be a little bit distracted. Okay. And so before I get to questions, I just wanted to hit, please, I need your help. I am involved with a research team, and we have developed a newborn discharge screening tool to identify newborns who are at risk. And we're in the pilot study phase, and I need people to test the tool for us. If you click on this link, it'll take you to a Qualtrics survey where you can you take this scenario and complete the survey. Okay, I need as many lactation professionals as I can get. Okay, you don't even have to be a lactation professional, but I need as many people answering this tool as I can so I can test my questions. Okay, so by the way, that's Emily when she was a baby. So what are your questions? I see the chat box has got like 39 comments in it, but I haven't had a chance to look at it. Anyone want to read some of the questions for me? What do you think, Rhonda?
So I think the majority of the the majority of it was comments, and they were talking amongst themselves. We did have a request for the link to the car video. So if you could email that along with the handout and then the link on the last slide. Sure. With the tool. So I can email that out to everybody also that participated.
Sure. So there's the link is here.
Okay.
But if you just Google search 24-hour crib site assistance, you'll pop up the whole site. Okay.
Okay.
But that's there. But yeah, you guys can all have my slides, and I'll send the sports handout and the slide with the link on it for that survey. I can certainly do that.
Okay. And like I said, the majority, it's comments, so you can go through and read through that.
Okay.
Just thank you, great video, and everything else. So
excellent.
It was really great.
Sounds good.
Thank you so much.
That was fun. I'm going to turn off my camera.
Okay. We enjoyed it. Thank you.
Stop sharing my screen, don't I? There we go.
Perfect. Okay. So next we have Lisa is going to talk to us. So we will give her a second also to get her screen share ready.
Okay, can you guys all see my screen and hear me?
We can see you and we can hear you.
Perfect. Well, that was a fantastic presentation. I have to say that I would have loved for my husband to have had that presentation before we had our son. So thank you so much. My name's Lisa Schlintz. I am the State Breastfeeding Coordinator for the state of Missouri. So I work with both our WIC, or Women, Infant, and Children's program, and our maternal and child health program to promote and support breastfeeding. And actually, Kathy, I was so glad to see you today. A lot of the slides that I'm going to be presenting are from some earlier work Kathy did for USDA from the Loving Support, helping parents grow and glow. All right. So we do have some learning objectives today. We're going to talk about supporting moms in the first 2 weeks postpartum. And this is going to be really basic information that would be perfect for dads, for family members, for home visitors, PAT, WIC, anybody that is around mom in those first 2 weeks. We're going to talk about skin to skin. We're going to talk about positioning and latching. I'm going to try to go pretty quickly so that we can finish up today. So probably the most important thing that I can say from our WIC office perspective is have moms call when the concern is small. Call while it's small. Most breastfeeding challenges can be prevented if we get there early enough, and we can help manage those with some support and provide some options. But what I know from my experience with moms is that we tell them, call me, just call me if you have a question. I'd love to help you, just call me. And mom is sitting on the couch crying, and the baby's crying, and maybe dad's crying, and nobody's calling. So one of the best things that we can do is make sure when you're talking to mom prenatally that your phone number is programmed into her phone so that she's got that handy so she can call. And then of course at WIC particularly, we do a lot of proactive outreach to moms. So we are calling a couple days after the baby's born and we're saying, how's everything going? And we're calling it that 10-day growth spurt. And I think that's the best way we can support our new moms. So those first 2 weeks, I think everybody knows those are a critical learning period. And I'll be honest, I don't remember a lot of the first 2 weeks after my son was born between sleep deprivation and breastfeeding and taking on that new role. It's all kind of a haze. And I think we need to remember that when we're talking to moms, and moms need to know that breastfeeding is going to get easier, that this is going to get better, that it's going to become more natural feeling, and that dads can give them a nap and it will get better. So in that first hour, we really want to talk to moms about requesting that the hospital put baby skin to skin. And I know from my work with hospitals that this is becoming the protocol at more and more of our Missouri birthing centers. So skin to skin contact is going to warm the baby up. It decreases pain and stress, both in mom and baby. Helps baby's immune system. It reduces crying and improves attachment and breastfeeding. And as we saw in those earlier pictures, dad can do skin to skin, grandma, siblings can do skin to skin, but this first hour, we'd really like it to be with mom because what we know is that baby's probably going to go to breast and start nursing. Babies learn through all 5 of their senses, and skin to skin contact engages every sense. Baby is touching mom. They're hearing her heartbeat and voice. They are seeing her face. Babies focus best about 12 inches away, which is just about the distance from mom's arm to her face. They are smelling her and they're tasting that breast milk and that taste of their mama. So for success in the first few days, there are some things that are really crucial. And one is that mom have skin to skin time with baby, that we avoid separation. So we're not taking baby out of the room to do things, but instead we're letting baby room in with mom so that she can see those early feeding cues and feed baby on demand. We want her to feed at least 8 times. We would like to see more than that. One of my NICU nurse friends says you should keep them within a foot of the breast and feed them every time they squeak. And I think that's something that sticks with moms and dads, and it's really easy to follow. You're not going to overfeed a breastfed baby, so feed them every time they squeak. We want to delay that first bath, and we're seeing more of our hospitals choose 8 hours, 12 hours after birth to give that bath, or even longer. Avoid a lot of artificial smells. We don't need to have perfume or essential oils on mom or anything like that. We want baby to be able to smell mom. And then delay visitors as long as we can. And of course, with the pandemic response, we've taken delaying visitors to a whole new level. But what I'm hearing from the nurses that I work with is that this has been great for moms for breastfeeding because there's nobody coming in and interrupting that. So there's been bad parts about how moms have been treated being separated from babies in some cases, but there's been some good too. So we like to talk to moms about what to expect with breastfeeding. So breastfeeding shouldn't hurt, but I'm never going to tell a mom that they're not going to notice that there's a baby nursing at their breast, especially if this is their first baby. There's going to be some tugging. There may be kind of a moment as the baby latches on. She may have some uterine contractions, particularly while she's in the hospital and in those first couple weeks. So she's going to notice it. But if she's nursing her baby with her hands clenched and her forehead furrowed and her toes are curled up, that's a problem. So pain is a red flag. We want her to try something different. We want her to call us for help. We can refer her to a lactation consultant. In WIC, we'll start with our breastfeeding peer counselors. They typically handle a lot of really common breastfeeding issues. And we're going to try and help her fix that position and latch. That's the real key to comfort at the breast. There is no perfect breastfeeding position. I like to say that there are 360 different ways to breastfeed a baby. And as the mother of a breastfed baby, now an older child, I think I have done all of these. I've nursed him over my shoulder, upside down. We've nursed in swings. We've nursed everywhere. So no position is going to fit all needs. But there are some things in common and some things that we can teach new moms to help them be more comfortable. We can use lots of pillows if needed. Some moms like to support their breast. I like just regular pillows. There are lots of breastfeeding aids or breastfeeding pillows that are sold. Some of them are more useful than others. Moms often get them as shower gifts and they're fine. But just let her know that there's lots of different positions. Laid back breastfeeding or biological nursing can sometimes help. And it's exactly what it sounds like. Mom just kicks back, puts the baby on top of her. And so we're working with instead of against gravity then. So baby's head is pushing down towards the breast and helping them stay latched on. So what does a good latch look like? I agree. Right? So baby's chin is pressed against mom's breast. The mouth is open wide and the lips are flanged. Baby's tongue is extended. Mom can hear and see swallowing. And most importantly, mom is free of pain. So if you have a baby who looks like this, they're well into the breast, that mouth is nice and open, but mom is clenching up, then something's not right on the inside. We need to start over or try again. I'm going to skip this animated latch, but there are lots of videos on YouTube about how to latch a baby. Some of them show what's going on with the tongue inside, and I recommend that you look those up. But for the sake of time, we'll skip that today. There's a couple different holds we can teach moms. And again, there's no right way to nurse a baby, but some of these mom will have seen in other media. Some of them are kind of come naturally. So the cradle hold is frequently how we're holding babies if we've ever bottle fed them. I honestly don't love the cradle hold for brand new babies because I think it's easy to get that head too far up into the elbow. So I'm going to help mom with whatever position seems to work best for her, but this is one you can start with. I actually love the cross cradle hold for young babies. And you can see, I don't know if you guys can see my pointer, but in this picture, she's got her hands supporting that baby's neck and back. And so baby's really well supported. Mom's got good control of where the baby's positioned at. This is wonderful for preterm babies, babies with latch issues, moms that have a larger breast, and it provides really good head control. The football hold is another one, and it's exactly what it sounds like. You're holding a football like you're running down the field. It's great for moms who have had a cesarean birth because it keeps the baby well away from her incision. It can be good for twins, although I've also seen twins kind of lay on top of each other and nurse. Babies that have trouble getting their tongue down. So if they tend to keep their tongue up towards the top of their mouth, this helps gravity pull that tongue down. And it's really nice, I think, particularly for moms that have a large breast, because what I hear from those moms is they're very concerned that their baby's going to suffocate. So in this position, mom can see baby's eyes and nose and can tell that the baby's really okay. So this can be very helpful for those moms. Laying down is a fantastic position. It helps relieve pressure postpartum. It's good for babies that won't latch in other positions. It's good for mom to get a little bit of rest while she's nursing, so she's kind of hazing out. And then this is that laid back breastfeeding position. And this we find really useful for new moms. Because baby's on top of mom, their head is pressing down towards the breast. They can open really nice and latch onto that breast. Mom doesn't have to provide a lot of support because her whole body is cradling her baby. So her hands are free to kind of reposition and stroke her baby and just be in that moment. You can get more information on that by going to the Biological Nurturing website. There are some videos, including some good clips. So normally when we do this talk, we're in person, and I would ask you all what kinds of adjustments you would make. Since I can't see the chat box, I'm not going to do that today. But I can tell you some things that I would look at here. On the left picture, this mom has her hand holding the back of the baby's head. And that might be offensive to some babies. When you put your hand on the back of their head, they have a reflex to kick their head back like that. And that can interfere with breastfeeding. It does look like baby's nose is fairly clear of the breast, but it can't really see the lips, but it doesn't look like baby has a very wide gape here. And this baby's not tucked in and supported really nice along the back. This baby on the right, you can see really needs to turn in. So they're turned sideways. And if you've ever tried to take a drink from this position, you can tell that that's a really awkward way to nurse. So I would turn that baby in. So we can help moms build confidence in their milk production. A really important thing is just breastfeed early and often. So we just keep them within a foot of the breast, nurse them every time they squeak. We can explain supply and demand. I like to talk about it like a factory. So we have to put in our order at the factory before we can pick up the goods, right? Right. So the more mom is going to breastfeed, the more milk she's going to have. We can talk to her about baby's tummy not holding very much. We can talk to her about how her feeding pattern for her breastfed baby may be different from formula-fed babies she's had experience with in the past. I love to talk to moms about hunger and satiety cues. This is really what I tell new moms. Feed them when they're hungry and stop when they're full. It's as simple as that, but we need to know what hungry looks like and what full looks like. So hunger signs include things like sucking on the hands, rooting, head and mouth movements. If they're a newborn and they're awake and moving around, they are probably hungry. Moms need to know that crying is a late sign of hunger because most of them think that you feed a baby when they cry. And you will often see them putting a pacifier in the baby's mouth and kind of trying to soothe them. They should just go ahead and put them right on the breast. They do need to know if their baby's born early or if they have jaundice or some other health issues. They may not show strong feeding signs. So for those moms, we might help them to figure out a little bit of a routine, not a schedule per se, but a routine about when they're going to wake baby up and offer the breast. And then signs of satiety. Number one is baby ends the feeding on their own and they kind of loll backwards and they look a little, we call it milk drunk. Their hands will relax. A lot of times they'll drift right off to sleep. If we have a sleepy baby that we're trying to wake up to feed, we can stroke their cheek, hold them in an upright position so they're not laying back, massage them, talk to them, get them undressed, change their diaper, put them skin to skin with mom. Those are the best ways to get a baby interested in feeding. And then mom can do some breast compression where she's kind of helping the milk come out to help baby stay awake. Moms need to know fussiness in the early days is really normal and it's not related to her milk supply. It doesn't mean she doesn't have enough. Babies are in this whole new world and they have a strong need to be held, and they have a need to suck beyond their need to have milk. So we need to talk to her about how normal that is. Your baby wants to be with you. She wants to be held by you or dad or your other supporters. Cluster feeding is really normal, so your baby may nurse every hour for 5 hours. Fussy babies that are not showing hunger cues probably don't need to be fed, and that's important for moms to know too. Everybody wants to know how to know baby's getting enough milk, and this is important. On the clinical side, we want to look at weight gain, so babies should be gaining 4 to 7 ounces a week in the first couple weeks. They should be fed at least 8 times a day. They should be waking up when they're hungry to feed, and they should show signs that they're satisfied. Mom should be hearing swallowing, and I like to use a little video clip when I'm working with new moms so she can hear what that swallowing sounds like. And then there should be plenty of soiled diapers, and mom should feel some change in her breasts throughout the feeding. So she should feel fuller at the beginning of the feeding and a little softer at the end of the feeding. We can provide weight checks, and so this is something we do at the WIC offices. You can come in anytime that you want to weigh your new baby, and we'll just pop them on the scale and just see how they're doing.
A lot of help today with the backyard, so I'd let you guys go out. So it would be nice if you help me with the backyard.
Somebody is talking. Let me try to mute the sound, everybody.
You bet. So we want to really start looking at intervening if we're seeing more than a 7 to 10% weight loss from birth weight. We need to do some assessment on mom's supply. If baby's losing weight after mature milk production begins around day 3 to 5, or if we see a baby with black tarry stools after day 5, that's when we want to step in. We want to let moms know what urine and bowel movements will look like. Tell them if it's coming out, it's going in. And so a lot of times we'll have moms just make a stack of about 10 diapers at the beginning of the day. And then at the end of the next morning, they can see how many of those diapers were used. And that's a great way, easy way for mom to keep track of it so she's not having to mark something out. We do at the state of Missouri provide a number of breastfeeding resources, and you can find those by going to wic.mo.gov and clicking on the breastfeeding button. These resources are free. You can order them to use with your clients. We update them regularly, and we develop them with input from our Breastfeeding Coalition here in Missouri and from our WIC agencies. So we do have one that has a diaper diary on the back. On the other side, it talks about all the things we just discussed about getting enough milk. Some moms like these because it's easy. They can just circle things when baby ate and when baby had a bowel movement or a wet diaper. There's also a lot of apps that moms can use on their phones, and I think that younger moms are probably more likely to use an app that keeps track of that. So our tips for new moms, all I want new mom to do is to work on having a baby. So I don't want her to work on having a perfect house or learning a new language or baking sourdough bread during her time with her new baby. I just want her to focus on having that new baby. She should go easy on activities. We're terrible at accepting help. So that can be dad's job in particular, is help support mom and give her permission to accept help from others. We want to rest and limit visitors. We don't want brand new moms should not be restricting calories. So we want her to make healthy food choices so that she'll feel good. Some of the best ways to do that are to pop some meals in the freezer that can be thrown in the crock pot and have some healthy things that are sitting out, fruit and cut up vegetables that are easy to grab. It's very common for mom to have baby blues in the first couple of weeks. If that continues beyond a couple of weeks, then we need to refer her to her provider. And every new mom I know has lots of questions and concerns, and I don't ever hear from my nieces as much as when they have a new baby. That's when I really get the text messages. We really want to avoid formula if we can in the first couple days, and this is what we talk to our moms about, especially at WIC. Even if they plan to partially breastfeed later, we want to get breastfeeding off to a good start and get her exclusively breastfeeding so that we can build that milk supply so that she continues to nurse and meets her goal, however long that may be. And then just provide her with those support and follow-ups. This is kind of random, but we do recommend vitamin D for every baby, and that should start in the first few days of life or in the first week. AAP recommends 400 international units a day. You can refer mom to baby's healthcare provider for that, but we want to make sure that's getting done. So to sum up, supporting moms in the first couple of weeks, we want to give her this guidance: breastfeed in the first hour, lots of skin to skin, get a good latch in position, feed them every time they squeak, avoid supplements, and just really affirm and support her goals. All right, I feel like I ran through that really quick. Any questions?
Let me double check the chat box. I'm not seeing anything.
That's fine. And if anyone would like the longer version, we do teach a 2-day version of this, and we're going to be doing it virtually in September. And you are welcome to sign up for that. It's on our wic.mo.gov website.
Okay. Thank you, Lisa.
Thank you.
Okay. Give me just a second. Okay. So next we have Adrian, and Lindsay is going to speak, and we are going to give her a second to get her screen shared, and she's calling in also, so we got to get that line unmuted. Oh. Well, okay, and in the meantime, while she's doing that, Lisa, we do have a question.
Yeah.
Let me pull it back up real quick. It disappeared on me. Okay. It asks, when is it normal for breastfed babies' soiled diapers to decrease?
Yeah, so babies will see a transition at around 6 to 8 weeks. Early on, mom's breast milk mostly has whey protein, which makes a really soft stool. So that's that breastfed blowout diaper that we're all used to, kind of a mustardy yellow. But around 6 to 8 weeks, that starts to transition. So mom has more casein protein. So if you've ever heard the old Little Miss Moffat sat on her tuffet eating her curds and whey, so think of those curds, or like the cheese part of cottage cheese. So that's about the time that those diapers are going to get a little thicker. They're not going to be really formed, but there will be fewer per day. So right around 6 to 8 weeks. And then again at 6 months, when we introduce solids, it's anybody's game at that point. I can still perfectly see a blueberry diaper that my son produced. Oh, okay.
Thank you.
You're welcome.
Okay, Adrian, do you guys want to try to say something and see if we can hear you?
Okay. Can you hear us?
I can hear you.
Okay, we're trying to get our screen pulled up here.
Oh,
do you see our screen?
It's pulling up right now. I can see it.
All right, good deal.
Perfect.
Okay, so we're so excited to be here presenting today, and thank you so much, Rhonda, for the opportunity. It's going to be myself, which is Adrian. My picture is the one that's on the left, and then Lindsay, her picture is on the right. Both of us, we work here at Poplar Bluff Regional Medical Center in Poplar Bluff, Missouri. We are the first 2 IBCLCs ever at our hospital, so something that we're both really super proud of, and glad to, you know, have gotten and to be able to help, you know, bring about good breastfeeding changes at our hospital and in our community. Do you want to talk a little bit about yourself, Lindsay, or?
Sure, I will. I'm Lindsay. As Adrian told you, one of the first IBCLCs here at the hospital, her and I are. We both became certified in 2017 is when we tested and got our results at the very end of that year. We had to wait 3 months for that, which was complete torture after you've worked so hard to get there. And then we worked part-time as lactation consultants here at the hospital and also worked the floor some. And then last year, around the fall, we became full-time lactation consultants. So we've been full-time lactation consultants here at our hospital for a little bit over a year, I believe.
Right.
And it has been a very rewarding and rewarding job and a very big blessing to both of us. I will kind of tell you a little bit about my life. So I have 2 children, and I'm currently expecting my third child. Breastfed both of my boys. I breastfed the first one for 12 months, the second one for 16 months. And the first one I struggled really, really hard with, and that was a huge factor in why I wanted to do this and why I wanted to support more breastfeeding mothers, because I really noticed that in this area that we live in, there is not a lot of support. In fact, at the time, that was back in 2014, at that time, there was literally no support that I could find other than WIC, and I did not qualify for WIC. So it was something that if I had not worked here at the hospital in the Women's Center and didn't have moms who had who had breastfed that I worked with, I literally would have had nobody to turn to. I don't really have any family members that have breastfed in the past, so I didn't have anybody there. But I really firmly feel like if I didn't have the ladies that I worked with that had breastfed, I would have thrown in the towel really early on, and I'm very thankful that I didn't. And that really, really pushed me, though, to make a change in this area. So I was very happy and very blessed to have the opportunity when it arose for our hospital to start the Baby Friendly Initiative and for them to offer us to go through the course. I was very, very blessed to be able to do that.
So we became Baby Friendly designated in 2018, and that's what we're going to talk today to you all a little bit about our becoming Baby Friendly designated, and just about like the process, and then talk a little bit about the 10 steps. So the first thing we're going to talk about is what exactly does it mean to be a baby-friendly hospital? So I'm not sure if everybody on here is familiar with it. Probably a lot of people are, but the first thing we're going to discuss is just what does it mean to be baby-friendly?
All right, so basically what it means, there's a lot of aspects to it, but the main thing is that to be a baby-friendly hospital, what that means is that your hospital and your staff support the 10 steps to successful breastfeeding. These 10 steps are evidence-based. They're an evidence-based bundle of maternity practices, and they support optimal breastfeeding as well as improving care and experience for all breastfeeding moms and non-breastfeeding families as well. The picture that is on there is of our hospital. This hospital was built
2013.
2013 is much, much different than the hospital we worked in before. Much larger hospital, and it's a very beautiful facility, and we're very lucky to have it. So the 10 steps, they're endorsed by the American Academy of Pediatrics, also the American Academy of Family Physicians and ACOG, American College of Obstetricians and Gynecologists. Poplar Bluff Regional Medical Center, we actively support breastfeeding as the optimal method for nutrition for all infants. We ensure that all families are provided ample opportunity to breastfeed and given quality education and sound guidance related to infant feedings. So what Baby Friendly is they are an institution. They're an accrediting body, a national authority for the Baby Friendly Health Hospital Initiative in the United States. They are responsible for coordinating and conducting all activities necessary to confer the prestigious Baby Friendly designation. They refine and uphold the standards and criteria for successfully implementing the 10 steps in the United States. They also assess and accredit birthing facilities that meet those standards and follow the International Code of Marketing of Breast Milk Substitutes.
Okay, so we're going to talk a little bit now about our journey to becoming baby friendly. Now that we've talked about what it means to be baby friendly, we're going to talk a little bit about our journey to becoming baby friendly. So we started in 2015 is when we actually started, and the way that that kind of happened was our hospital was part of the Empower Breastfeeding Initiative. I don't know if anybody's familiar with that at all, but basically it was a program that, you know, what was started to try to help more hospitals to become baby-friendly designated. And our hospital found out about this program by a local person in the community, and then we applied to be a part of it, and our hospital was chosen to become a part of the program. So we were really excited about that because it gave us a lot of assistance during the baby-friendly process. Not only did it give us financial assistance, because, you know, you have to, the hospital has to pay to be baby-friendly designated and during the different steps, but it also provided us with coaches to guide us during the process to help us. Like we had a RN and a lactation consultant that was a coach, and then there was also a physician coach, and basically they would they visited our hospital a couple of different times during the process, and they would just guide us and answer our questions. They would also correspond with us through emails and phone calls and, you know, video chats and different things like that, and basically just help us. And because anybody that's been through this knows that it's a very big process, and there's lots of questions and what's and whys and ifs and all that kind of stuff. So it was really amazing having them there to help guide us through it. Lindsay and I were a part of the team who led our hospital while working towards baby-friendly designation. You know, we are Women's Center Director. We did a lot of assistance with helping her and, you know, doing surveys and doing different things, you know, and trying to help change culture basically here and being, you know, team leads on that. So talking about changing culture, that process was definitely a huge, huge change for our staff, our physicians, and our community. You know, what everyone had always known here, and when, you know, people came in to deliver, totally, you know, pretty much went out the window, and everything, you know, changed during that process. We obtained the Missouri Show Me 5 in 2016 after we had completed 5 of the 10 steps that we had and were implemented, and they were in place. We received, honestly, you know, the most resistance from veteran nurses who had a lot of years of experience, who were very like set in their ways, and they didn't want to change, you know, and some people are just, they're hard to get them to budge. And then also younger nurses who didn't breastfeed their own children were the ones who were the most resistant to all the new practices and things that we were trying to implement. And definitely our physicians too, as well. Our physicians were, you know, always used to like, you know, especially when we started like implementing the rooming in step, and our physicians were always used to like in the mornings coming in, and all the babies would all be gathered from all the rooms, brought into the nurseries, all lined up in the nursery like a little assembly line, and so they could go through and assess all their babies really fast. And then whenever we started, you know, saying, no, you have to go to the room and assess your babies, and they kind of didn't like that at first. So like I said, we definitely, it didn't come without resistance for sure. Some of the things, though, that we did to try to kind of help with that was we had guest speakers come to our hospital to educate on the importance of breastfeeding and kind of to like receive buy-in from the staff and physicians to get them on board. And they were, one of the people that came, she was a lactation consultant, and she was also a physician, and she talked with our staff and our physicians about, like I said, about why breastfeeding is important, and about, you know, the 10 steps, and about baby friendly, and, you know, why it's a very important thing and something, you know, good for our hospital to be doing. We also would talk it up at all the staff meetings and would try to figure out what worked best by trial and error, and being open to comments and feedback from our staff and physicians. Like whenever they would come to us and be like, well, we tried this and this is not working. This is, you know, it's taking too long, or this process is really difficult. We would try to listen to their feedback and, you know, well, what do you think would help to improve this? You know, do you have any ideas on a different way that we can do it that might be more effective or efficient? And just make them feel like that their concerns and their ideas and everything, you know, were validated, and that we were listening to them and, you know, wanted to be there to help them. We would show and give them like latest evidence-based practices to support the changes that we are trying to make, to say that we're not just doing this to become baby friendly. Obviously that was our goal, but the main thing was to improve the care and the practices that we do to, you know, better the care that we give to our mothers and our, you know, infants and families overall. So having those evidence-based practices there to show them like, this is why we do this, because it helps to improve outcomes, not just, you know, because we're trying to become baby friendly, but it's really what's best for our patients. It was definitely not a process and something that happened overnight. It was definitely a very slow process, you know, one step at a time, little changes at a time that we went through. The majority of our patients were very pleased with our new practices, and particularly like the skin to skin immediately after delivery, like they were very, very happy with that. And they, especially patients that had delivered at our hospital in the past, and they knew like the old ways that we had done things, and then coming back to have a baby again later and seeing all the things that we had changed, they really, really loved it. Like I said, especially one of the first things that was really, you know, well accepted was that skin to skin immediately after delivery, you know, because I mean, just a mom obviously being able to be there and bond with her baby like that in that moment, that's such a special time for families, you know, they really, really loved it. So most of the patients accepted it very well. So we received our on-site survey from Baby Friendly Assessors in February of 2018. Remember, I said we started in 2015. And then finally by early in 2018, we were ready for our site visit, and that's whenever they came, which that is a 2-day process. And basically the assessors come and they look at every aspect of the 10 steps and review them, and then they want you know, evidence given by us to show and to prove that our hospital had properly implemented each and every step and that all the criteria had been met. They would go and not only, and it wasn't just about them talking to us or us having paper to show and say, hey, you know, we've done this, or, you know, we've implemented this. Like they also go and talk to the patients. They would go interview moms, like a certain number of vaginal deliveries and C-sections, and they would talk to them and they would ask them, you know, all these different questions about how their hospital visit had gone and what had happened since they had been here, and ask them if they had roomed in and skin to skin and all, you know, the different stuff, if they'd been, you know, assisted with breastfeeding. They also called moms at home and that had delivered 2 or 3 months ago as well, or prior to that time, and interviewed them. They interviewed our staff and would ask questions to our staff about, and wanted to make sure that our staff had basic knowledge in breastfeeding. And they would randomly pick staff members and as well as physicians to interview also. And then after we went through that 2-day survey, we received feedback, and we had to make a few minor improvements of things, nothing major, but just a few things that we had to improve. And then in August of 2018, we finally received our baby-friendly designation. This is a picture there of Lindsay and I with our poster saying that we had received the prestigious international baby-friendly designation that we're so super excited about. It was a really big thing. Our hospital put out, like, you know, press release to all the local media and everything. And we had like a big party and a celebration here at work, and that finally all of our hard work and everything that we had been through, you know, over the course of that 3 years had finally paid off. So, all right, so now we're going to talk a little bit about, we mentioned all about these 10 steps that is, you know, what the, you know, different changes and things that we made, but now we're going to talk about each of the 10 steps to successful breastfeeding and just touch on each one a little bit.
Okay, so step one, have a written breastfeeding policy that is routinely communicated to all healthcare staff. So during our process of becoming baby friendly, this was something that we did have to work on because we did not have a feeding policy before this. So when we wrote our feeding policy, some things that we had done, we had put in that policy, Adrian and I, and also our director, kind of sat down and discussed different things that needed to be in this policy. It is an 11-page policy. It is very large. But it basically, what it covers is it covers all 10 of these steps that we're going to discuss and kind of breaks them down into specifics of what needs to be happening with each of our infants. It's very specific, detailed policy. And it is there for our staff to guide our staff and our physicians to provide optimal care and support for breastfeeding families. It also defines procedures for breast milk collection and storage. So if we have a mom who is, a baby who is sick, who is separated from mom for some reason, or a mom who is pumping, you know, to provide extra breast milk for her infant, or hand expressing, then we would, in this policy, it has specific guidelines as far as milk storage and collection of this, and then also education for our non-breastfeeding families. So moms who have been educated on the importance of breastfeeding and have made an informed decision to not breastfeed, but rather provide formula for their infants. So it has safe formula preparation and feeding also in our policy so that we can provide that to our moms and our babies and make sure that they are thoroughly educated on the safety of providing those things. So number two, train all healthcare staff in the skills necessary to implement this policy. So all of our staff, when we first started our initiation, everybody who was here at the time went through and did a 15-hour course. We did it online. Initially what we did it on was it is Lactation Education Resource. Some of you may be familiar with that. That is also where Adrian and I did our training for our IBCLC. It is a very, very resourceful website. Even if you don't have purchase the different groups there's a lot of other education on there for families and for physicians and staff. So we completed 15 hours on this, on the Lactation Education Resource, and then 5 hours of clinical competencies. So that would be hands-on in a clinical setting, hands-on assisting with breastfeeding. Our new hires that we have now, what they do is within 6 months of hire, they are involved in, anybody who's going to be involved in direct patient care, they do a 15-hour course, and the course that we offer them is with our Advanced Learning Center, which is the learning center that our education department here at the hospital, it's what they use to provide education. So it's a little bit different than our original, what Lactation Education Resource had to offer, but the cost, I think, is more effective for the hospital, and it still offers all of the same information. So they do 15 hours worth of this education online, and then again, 5 hours of clinical competencies. Now that we have lactation consultants, our new hires are able to kind of do a rotation day with us where they come through and go to the bedside with us, and we can show them and teach them hands-on. And I really love doing that. I love being able to teach our new hires, and I feel like they're more involved when they're able to do that hands-on. We do also offer a skills fair that we do kind of routinely, maybe twice a year or so. And then we do yearly also, just as a refresher, we do more with our staff also, where we kind of do a couple-hour course where we just kind of go over everything again and do a big slideshow with all of the steps and all of it breaks down our feeding policy so that is routinely reviewed with everybody and kind of give them that refresher of knowledge. Step 3, inform all pregnant women about benefits and management of breastfeeding. So this is something that is really, really important, and it is also something that we have to really include our physicians in on, because our moms, a lot of them don't, when we see them, by the time we see them, usually it is during their delivery or after their delivery. We do offer prenatal visits where they can come in and do one-on-one, and we offer breastfeeding class that they can attend before they deliver, a prenatal breastfeeding class. We do that once a month, the breastfeeding class we do, but we also strongly encourage our OB doctors, our pediatricians, if they have moms, moms that they are seeing, that they educate them in the clinic before they get here to the hospital, so that they are already, by the time they get here, they have already been informed on the benefits of breastfeeding and how important those things are. And then by the time they're here, they can make that decision. Or if they're still on the fence, sometimes Adrian or I will go in and discuss with them and kind of give them more details and a little more teaching about breastfeeding so that they can make that decision before they deliver, so they feel a little bit more prepared. So the education needs to start from the first trimester, preferably, because from that point on you can kind of go through and provide little bits and information with each appointment to them, and that way you don't overwhelm them all at one time with the education. So Poplar Bluff Regional Medical Center, I talked about the prenatal breastfeeding class, and then also individual counseling. We don't do a lot of prenatal visits, but that is something that is available for them. So if their physician feels like they need more in-depth teaching, or they have more questions that they're not able to answer, or that they need more one-on-one time, that is something that is available here. Step 4, help mothers initiate breastfeeding within the first hour of birth. So our newborns, they remain skin to skin until the first breastfeed, or until the first solid hour if it's a family who chooses to formula feed. We strongly encourage these moms to watch for feeding cues, and then a lot of times our nurses are at the bedside usually for the first little bit after delivery, just kind of helping mom and monitoring mom's bleeding and all of those things. And so we are there to help them whenever they are initiating breastfeeding, and kind of, show them, like, here, this is your baby, your baby's chewing on its hands or it's rooting, it's time to try to breastfeed. So we do stay at the bedside usually for that first little bit and help that mom. We try not to interrupt or intervene with anything until that baby starts to cue, and then if mom needs help positioning or latching, we can offer that assistance to her. We do postpone all procedures during that time unless there is an issue, like if the baby comes out and we put it skin to skin and it's kind of struggling to transition a little, then we would, obviously take that baby to the warmer and maybe do a little more assessing and hook it up to a monitor to check it out. But ultimately, we want to leave that baby skin to skin and just try to let it transition there on mom's chest, and then help mom feed and notice when her baby is ready to eat for the first time. So step 5 is show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants. This one here, this is our nursing staff is usually who will assist with the first breastfeeding because they're the ones that are there at the bedside. If there is an issue though, and say, because some babies, they come out and they're not as aggressive, or they want to feed but they're really struggling. So if there is an issue, a lot of times Adrian or myself will go in and we may help with that initial feeding or with latching and positioning. But for the most part, our nursing staff initiates that assistance if it's needed, and then we go back in if there's further intervention that needs to be done. So our nursing staff, along with lactation, provides the education and support for the latching and positioning techniques. If a mother and baby are separated for some reason, then the infant isn't available to go to the breast or able to go to the breast, those moms are set up with a double electric pump and also taught effective hand expression. And then we prefer for that to occur within the first hour after delivery if we know that that baby is going to be staying in the nursery for a long time, or if that baby has been shipped out for some reason and transferred to a different facility, then we want to get on that as soon as possible. So preferably within the first hour, but we like it to be absolutely within the first 6 hours after delivery. So this is something we really struggle with, because our staff a lot of times, especially like the nursery staff, they'll be, they're stuck there trying to help this baby and trying to get this baby settled who is struggling. And so sometimes that kind of goes to the kind of slides under the table where they forget to do those things. So Adrian and I are usually pretty good though about paying attention, and if we know they have a sick baby in the nursery, we'll try to jump on that and get that mom set up. We also strongly encourage our labor and delivery staff and our postpartum staff to pay attention to those things too, and to always ask that mom, once, you know, especially if she's been separated, are you planning on breastfeeding? And if so, let's go ahead and set you up with a pump. So anybody within our facility can set that mom up with a pump, as long as, but we encourage that the nursing staff or somebody that is a nurse goes in and makes sure that all of those things are done correctly shortly after it's been set up.
Step 6 is give infants no food or drink other than breast milk unless medically indicated. We avoid formula supplements in breastfed babies unless there is a true clinical indication. We don't give babies formula, like I said, unless, you know, there is a true medical reason for it. If a breastfeeding mother, though, requests that her infant be fed formula, the staff nurse caring for the baby is responsible for exploring the mother's questions and concerns about feeding and educating her regarding the possible negative consequences of feeding her infant formula, and trying to, try to persuade her, on continuing to breastfeed, and the importance of exclusivity. Sometimes it can be something as simple as, well, I don't think my baby is getting enough, and when it all boiled down to it, it was basically because her baby was cluster feeding, and that's why she didn't think her baby was getting enough. And then with a little bit of extra education, she's like, oh, okay, then my baby's doing fine. Then I don't think we need formula. So sometimes it's something simple that the mother just has a concern about, that if someone just takes a little bit of extra time to talk and explain to her, we can, help her to continue exclusively breastfeeding and not giving formula. If the mother decides, though, to feed her infant formula after receiving the education from a staff member, then we absolutely support her choice. We're not here, we're not forcing anyone to breastfeed that doesn't want to. It's about making informed decision and about her being educated. And if she's been educated and she still chooses to give formula, then we support her decision. And we tell our staff knows that, they're to respectfully do that. If it is determined that a breastfed infant needs to be supplemented with formula for a medical reason, like if they're, have a significant amount of weight loss, or, if they have a really high bilirubin level, and we've done other measures and, we do it as the last resort. But if it is determined that they do need formula supplementation, a written order is required by the physician on the chart in order for the nurse to be able to give the infant formula, or the mother. Step 7, practice rooming in. Allow mothers and infants to remain together 24 hours a day. This is a picture on the side of one of our postpartum rooms over there. So rooming in applies to all mothers and infants regardless of feeding choice, whether they're breastfeeding or formula feeding. All of our babies room in 24 hours a day. All the routine procedures are performed at the mother's bedside, including like the baths, weight, vital signs, labs, meds, all of that. Anything basically is done at the bedside, other with, than just the exception of the surgical procedures such as like a circumcision, or if we have a baby that, has a, tongue tie, is going to get a frenotomy, then they would go to the nursery for a short period for that. But then as soon as it's done, they're taken right back to the room. And I heard, mention about, somebody was talking about the baths earlier and about delaying baths. We do delay our baths here. At least we want at least 12 hours after birth before we do baths. Sometimes longer than that, if the parents are okay with it. But we delay it at least 12 hours. If a mother requests her infant to be taken to the nursery, and sometimes they do that, because they'll say, well, I'm really tired, or I want to get some rest. Our nursing staff educates the mother on the benefits of rooming in and explains to her, why it's important for the baby to room in, for her to watch for her baby's feeding cues, and so that her baby, can feed on demand, and, for bonding and everything like that. But if she still insists after the education is provided, then the nurse takes the infant to the nursery and then returns the infant when the mother requests, or when feeding cues are noted. And then last thing about this, if rooming in with the mother is ever a legitimate threat to the infant's safety, we always, always, always consider safety first, in which case the infant is taken to the nursery. I know there's been different talk about this, and I've seen news articles and things on social media about rooming in, and people talking negatively about it. Like when, you have mothers that are really tired and, that it might be a safety concern or issue. And, every patient is different, and you have to assess each one individually. Everything is not always black and white. There are some gray areas. And, we've really stressed to our staff that if it is ever a safety issue, then we always consider that the safety of the infant, as our utmost priority. And then, like I said, the baby would be taken to the nursery. And one of the examples of that is sometimes we have a C-section mom, and she doesn't have any support person staying with her. And she's, some of our physicians use PCAs for our C-sections. Not all of them do, but some of them use like morphine PCAs. So like if the mother's on a morphine PCA after a C-section and, she's in bed and she has a catheter in and she's really groggy, she's drowsy, she can't hardly stay awake, and she doesn't have anybody there to help her and to, a support person there. And, it definitely would be a safety concern for her trying to care for her infant by herself. So in those cases, it is definitely appropriate for the infant to be, taken to the nursery if needed. Step 8, encourage breastfeeding on demand. We instruct our mothers to feed their infants without restriction, and when hunger cues are noted, our staff educates them on watching for those hunger cues, what those hunger cues look like. And the mothers are taught to feed their infants as much and as often as they desire, with a goal of at least 8 or more feedings in every 24 hours. We teach them that that's what we consider an adequate amount of feedings, would be at least 8 or more in a 24-hour period. And we encourage the parents to avoid setting limitations regarding the length or number of feedings. Sometimes, parents want to be like, well, my baby just ate, an hour ago, he can't be hungry already. So we try to really encourage them, yes, I understand that, but your baby is giving feeding cues, so you need to go ahead and put your baby back to the breast. Step 9, give no pacifiers or artificial nipples to breastfeeding infants. We educate mothers to avoid providing their infants with pacifiers or feeding from a bottle in the first 3 to 4 weeks while breastfeeding is being established. We all know and understand that it's proven that whenever those artificial nipples are introduced in the early newborn days, that it can cause hindrance to breastfeeding by one of the main ones being nipple confusion, and making it difficult for the baby to latch. And then another thing, we have moms will be like, well, what about just pumping and giving the baby my breast milk from a bottle? And then we explain to them that, milk flows a lot faster from a bottle than it does from the breast, and sometimes if you start giving that bottle early on before breastfeeding is well established, that when you try putting the baby back to the breast, then the baby gets frustrated, because it has to work a lot harder, to get that from the breast than what it does from a bottle, and it can make it difficult, and like I said, cause hindrance to breastfeeding. So we try to encourage them to avoid those things for that first 3 to 4 weeks. And then if supplementation is required, like if a mother is pumping, like if there's a reason, like for, like I said, weight loss or jaundice or whatever, reason if we're giving, her EBM, or if there is a medical order for a formula supplementation, then we encourage the use of an alternative feeding method to provide that supplementation, using either a syringe, cup, or a spoon, to avoid the use of a bottle nipple. Most of us here prefer our method that we really like to use the most is a syringe, because it's very, it's easy to draw up in a syringe, and it's very, the amounts that you're giving, you can see, and it's very accurate. So we like to use a syringe often, and sometimes we'll even do like a finger feeding and like let the infant, suck on like a gloved finger while syringing the supplementation into the side of the mouth. Some of our nurses will use a cup or a spoon also. Not as many of them. Like I said, the majority of us do a syringe, but we do have some that will use a cup or a spoon as well. And then last, step 10, foster the establishment of breastfeeding support groups and refer mothers to them on discharge from the hospital. This is really important, and we want to make sure that all our patients know where to turn to for help. Like Lindsay said, it's not been that many years ago that there wasn't very much help and support, you know, and we want our moms to be successful, of course, with breastfeeding and to meet their breastfeeding goals. So when they're discharged, we make them aware of the different avenues that are available to them to get support. So we offer a baby cafe here twice a month, which is a support group that's open to all breastfeeding moms that we have available here at our hospital. Our local WIC department also has a support group every other month as well that they do. We offer outpatient lactation consultations here now as well. We have to have a physician order to be able to do those, but our pediatricians or our OB doctors are really good that if a mom calls them or goes into the clinic to see them and they're struggling with breastfeeding or there's some kind of concern, they will usually write an order and call us and refer them to us, and then they come back here to the hospital to our office, and we do an outpatient visit with them and just, you know, sit and watch their baby breastfeed and try to, you know, help them work through whatever problem they're experiencing and, you know, give them tips and recommendations on what can be done to help their situation. And then our mothers are made aware of how to gain access to this breastfeeding support, like I talked about, if needed after discharge, because obviously we all know it is very important, and, you know, having that support available there helps to increase the duration of breastfeeding. And so we, like I said, we want them to know that we're still here and still available to help them. And that is all I think that we have. Do we have anybody that has any questions? Or I haven't really looked at the chat box or anything, Rhonda.
We do have a few questions.
Sure.
Okay, so the first one, did your staff have difficulty keeping the baby skin to skin within the first hour? And then also, how did you help nurses understand the value in waiting to do weights and other non-profit immediate procedures?
Okay, so as far as the skin to skin, actually, I think that was probably the easiest step for us, truthfully. That was the very first step that we started with. After we started our baby-friendly, you know, process, that was the first step. That's kind of how we did. We would do kind of work on like one step at a time is what we did. And then kind of once we got that step sort of, you know, quote unquote mastered, I won't say mastered, but, you know, we got it down for the most part, then we would move on to a new step. But the very first one we did was skin to skin. And I feel like that was one of the easiest ones and the one that, you know, that came most natural without, you know, fuss. There were some, you know, nurses that are like, well, I can't get the, you know, why can't I get the weight, or I need the weight for this, or well, the weight is not necessary to get, you know, immediately. It's not something that, you know, that you have to have that has to be done. I believe whenever we first, before we had started the process, whenever our nurses called to admit our babies through admitting, the weight was one of the things that they gave to the admitting people, you know, like told them like whether it was a male or female, vaginal or C-section, you know, the time, and then they would give like the weight and the information too. And then they eliminated that to be able to be done after that, you know, initial time of skin to skin and everything, which helped that process. Because really, I mean, there's not a need to have that weight immediately, you know, I mean, you know, yeah, unless the infant's ill. And of course, then if the infant's ill and it's really sick, then it's not going skin to skin. You know, if it's having, you know, true respiratory distress or something, then obviously it's going to the nursery and it's not going skin to skin with mom. And then what was the other question that you said, the second question? Are you still there?
Can you hear me? I was muted. I apologize.
Oh, yeah, I can hear you now. Yes.
Okay, so I think you answered both of those questions. And then the next ones are, so any suggestions on how to help change hospital culture about supplementing without using a bottle? And then also, do you use a periodontal syringe for larger volumes?
So as far as the helping to change about the not supplementing with a bottle, like that is a step that we have struggled with, and you know we still sometimes struggle with that. But just
lots of reinforcement,
and re-education on why it's important, you know, and especially like whenever Lindsay and I have a baby, like for instance, like that, say the mom has, you know, she's been educated, but she still wants to breast and, you know, bottle feed both. And of course, like we support her in that, but then after her baby has had a few bottles, then we struggle getting it to feed at the breast. We try to really, you know, like point that out to our nursery nurses, you know, and, you know, tell them, you know, this is why we recommend not giving the supplementation with the bottle, because it just flows so fast and it's like instant gratification for the infant. And then if the mother is, you know, like I said, insistent on doing breast and formula feeding both, we try to ensure that we're teaching them about doing paced bottle feeding. Which is something that, you know, does help. It's still a bottle and still a nipple, but if you do the paced bottle feeding technique, it is something that will help that as well. But ultimately, like I said, if mom's goal is to exclusively breastfeed, then we want to, if supplementation has to be given, then we want to not give the bottle nipple.
Thank you so much. And I think
You're welcome.
that was all of them.
Okay.
Thank you guys. Thanks.
Thank you very much.
Okay, so we are going to get ready to close out. Let me get, Adrian, can you guys stop your screen share? Okay, there it goes.
I did.
Perfect. Okay. Go. Okay, can everybody see my screen okay? Okay, I see some thumbs up. Okay, perfect. Okay, so before we close out, we just wanted to highlight our breastfeeding success stories. I know you guys received those in the program. A link came out with your reminder, but I'm also going to send a PDF copy of that. So we just encourage everybody to read those, and then you can also visit our website, which is linked to the program as well, to view other success stories of our clients. So we had these ones and these ones. And then the other thing is the evaluations. So everybody is going to receive an evaluation via email, and we're going to give everybody until the 21st to complete the evaluation. And then everybody that completes that evaluation will be entered in for the $100 gift card. And we're just going to do like a randomized automated drawing for that on the 24th. And then we will reach out by email. And then also you guys will get the certificate of completion in the email. So your email is going to have the recording, the certificate of completion, evaluation. A lot of you have requested different links and materials. So I will also add all of that to the email. And then if anybody has any questions or anything, feel free to reach out to me. And then we are also, Ms. Dean has a few more things that she would like to share as well.
Can you hear me? Thank you, Rhonda. This has been a very exceptional workshop, and I learned a lot. And I just think that we couldn't have picked a better group of speakers for this specific workshop. And the comments through the chat box agree as well. And we're excited because we will be hosting another virtual workshop in September. Next month is National Infant Mortality Month. And this will be an opportunity again for us to connect. Many of you, I hope, will join us. And we also have a link at the end of the session here where you can register for that. That's coming up on Friday, September the 18th. And we'll also have national speakers and presenters that will be part of that workshop. But again, we want to thank you, and everyone stay safe. And again, thank you, Rhonda, for all of your work. Goodbye.
Bye, guys. Thank you, Miss Dean.
Bye-bye.
Thank you, guys. Okay, so that should be it. Okay, I'm like, where's my phone?
Right there.
I'll see if, you know, I don't have a call. Ask if they have a neonatal